Good morning. Thank you all for being here this morning. Welcome to the Interim Committee on Health and Human Services. And let's start with Secretary. Will you please call the roll?
Senator Dunyate, Senator Lang, Senator Titus,
I'm here.
Assemblymember Edgeworth, Assemblymember Goulding,
I'm here.
Assemblymember Hibbets,
Here.
Assemblymember Nadeem, Chair Brown-May.
I am here. Thank you. Please mark Senator Dunyate present when he arrives. He's running just a little bit behind schedule today. Before we begin, I want to just make several housekeeping announcements. First, as a reminder, please silence your electronic devices, especially your cell phones and your laptops. Mine just went off a minute ago. Agenda items may be taken in a different order than listed. We don't anticipate that. However, it is always a possibility, and 2 or more agenda items may be combined for consideration. The committee's meeting material can be found on the Nevada Legislature's website. You can also sign up for electronic notifications related to any activity on the committee's website. And if you wish to testify in person, sign in at the table. Leave us a business card, please. When testifying in person, turn on the microphone to speak and then off to listen. We have others that are listening and viewing meeting in Las Vegas, up in Carson City, and online. With that, we will officially move to public comment. Public comment is limited to 2 minutes. If you would like to offer public comment, please come forward. Fill in the seats. Staff will time each speaker during public comment to just ensure that everyone has a fair opportunity to speak. In addition to testifying in person, members of the public may provide public comment in lots of other ways, all of which are listed on the agenda. And if you would like to call in to provide telephonic testimony, please dial 888-475-4499, and then when prompted, provide the meeting ID. Enter 857-3089-0851, and then press the pound sign. When prompted to provide a participant ID, press the pound sign again. With that, we'll start with public comment for those in physical locations, and then we'll move to public comment online. So here, we'll start here in Las Vegas. Please state and spell your name for the record. You may begin when you're ready.
Patty McGuire, Pattimcguire. Good morning. My name is, like I said, Patty McGuire, and I am the Pastoral Associate for the Human Concerns Ministry and Outreach and Food Pantry Coordinator at St. Elizabeth Ann Seton Catholic Church. And I am here today representing Nevadans for the Common Good, NCG, which is a broad-based, nonpartisan community organization made up of 30 congregations, neighborhood coalitions, and community nonprofits, representing thousands of families in Southern Nevada. In November of this past year, our congregations, nonprofits, and food pantries were overwhelmed when people lost their SNAP benefits during the government shutdown. This recalled our experience during the pandemic when we all faced endless lines for food and housing assistance. It was chaos and people suffered. Through our work, we have talked to over 1,000 people, so we know Nevadans are already beginning to feel the impact of what we know is coming with the full brunt of H.R. 1. People with eligibility letters, people with questions, people who are fearful of losing benefits are already showing up to our churches, food pantries, and food lines to try and find help. Understanding the healthcare system can be daunting to everyone as eligibility for Medicaid and SNAP changes, public resources for clinics and hospitals shrink, and the cost of private insurance increases. An already strained and confusing system will now be forced to deal with an increase of people needing help navigating. They need face-to-face navigation help in location that is familiar and trusted, such as a church or community center. In reality, this is where many people go seeking help. Faith formation leaders and pantry managers, including myself, have shared how we are frequently asked questions we are not equipped to answer, such as, how do I apply for Medicaid or SNAP? How can I find housing that I can afford? My power was disconnected. What can I do? Most people seeking help have multiple needs, so finding solutions can be complex. As our entire state social safety net faces the dramatic loss of federal revenue and an overwhelming increase in demand, Nevadans for the Common Good strongly advocates for a coordinated face-to-face navigation system with trained navigators located throughout the valley, particularly in neighborhoods most affected by the coming program changes. Technology alone cannot fix this. Having navigators located only within the healthcare system also doesn't solve the problem. We need face-to-face assistance in trusted institutions. Thank you.
Chair Brown-May, members of the committee, Connor Cain, C-O-N-N-O-R-C-A-I-N, on behalf of HTA Healthcare and the Sunrise Health System. In front of you today, just to thank you for making time to look at this really impactful piece of legislation at the federal level. As many of you know, Sunrise Hospital is our state's largest acute care facility. It's also our state's largest provider of Medicaid services. 19% of Nevadans who receive care under the Medicaid program receive that care at Sunrise Hospital. That's roughly 1 in 5 Nevadans. Something that we're incredibly proud of. We want to continue to work with this committee, with the health authority, with the state, to continue to provide those critical services. And again, we thank you for looking further into the future and calling this meeting today. Thank you.
Hi, Liz Ortenberger for the record, Lizortenberger, and I serve as the CEO for SafeNest. And I'm here today to talk about the HR1 work requirements related to Medicaid. At SafeNest, we currently have 40,000 volunteer hours available every year. These are not simply informal volunteering opportunities. They are technical, and they are log in, log out, and geocached to ensure that people actually are doing the volunteer hours that they have signed up for, and they are also tracked by supervisors. This opportunity will be missed if we do not allow organizations like SafeNest to be part of the HR1 volunteer requirement to Medicaid. Looking ahead, we will be having 60,000 plus hours on our campus as we open October 15th. Medicaid is designed to help the clients that we work with, and we want to be part of the solution. We stand ready to partner with the state, the county, and the city to make this possible. And I am not alone as a volunteer organization. SafeNest is one of many who has this opportunity available. Thank you.
Thank you. Is there anyone else here in Las Vegas or in Carson City who would like to offer public comment at this time? Seeing none, we'll go to AVH. Is there anyone on the telephone line who would like to offer public comment?
Thank you, Chair. The public line is open and working. We have no callers for public comment at this time.
Thank you, AVH. Okay, we will wrap up our public comment phase and prepare to move into the next section on our agenda. Before we do that, I want to take a moment of personal privilege as we have our members here and present. I want to recognize our distinguished colleague, who is celebrating the anniversary of the next turn around the sun. Senator Lang, we wish you all the very best and are grateful that you are here with us spending your birthday in committee. And so on behalf of the entire committee, we want to wish you the very best day. Thank you for sharing it with us. Thank you. Okay, that was a nice moment of levity. Let's move into the topic and why we're here, right? As you are all aware, today's very focused topic is about the impacts on HR1, the federal legislation that is making changes through much of our state. So I'm going to go ahead and open up the next agenda item and ask our presenters to come forward. So we're going to hear from the Nevada Health Authority on the impacts of HR1 and the federal legislation. I'm sure we will have lots and lots of comments. So at your convenience, if you will, please take the testimony table, and we look forward to hearing your presentation.
Good morning, Madam Chair, committee members. Stacy Weeks for the record, Director of Nevada Health Authority. Thank you for having us today. I have with me Ann Jensen, our Administrator of Nevada Medicaid, as well as Melinda Southard, who is in the Carson City office. So she should probably be on the screen if you can see her. She's here to also talk and present some of these slides. Also have additional team members here in the audience in case there are questions about a variety of the topics. We're going to kick it off and kind of hand off, but we're going to start with Medicaid. There are a couple of things for the exchange as well. So I'm going to go ahead and just start the presentation. Current slide. All right. So first, we're going to talk generally about high level, some of the big key changes we see from HR 1 for any of our programs at the Nevada Health Authority. Second, we're going to dive in a little bit to HR 1 fiscal and budget. I know this is not a budget committee, but I think it's important to understand some of those pieces. And so I will be doing a little 101 on Medicaid budget just to ground us. And then last but not least is let's look at the bigger picture on healthcare for the state. And then we'll open it up for questions. All right, Anne, I think this is you.
Good morning, Madam Chair, committee members. Ann Jensen for the record. As Stacy shared, I'm the Medicaid director here in Nevada, and I'm excited to share a little bit more about the work we've been doing for nearly the past year to prepare for and implement the new federal legislation, what we'll refer to here as HR 1. So what I'd really like to communicate and what I hope is clear in our presentation today is this isn't a really complex piece of federal legislation that has two really specific impacts on our Nevada Medicaid program. All 56 Medicaid programs in the US are experiencing these changes differently. And what we really want to communicate is exactly what this looks like in Nevada. For us, those changes are felt in two categories. Firstly, on who can maintain and earn eligibility to the Medicaid program. That will change starting January of this year primarily. And the second impact is on our hospital provider tax program. So for most of my time today, I'll be sharing more on those eligibility policy changes, and then I'll turn it back to Stacy to share more on the hospital provider tax program. What I also hope is clear through each of our slides is that we are deeply committed to avoiding coverage loss and ensuring continuity of care and coverage for Nevadans so that people can choose the health plan that is high quality and affordable to them. We're also committed to the sustainability of our program and are working hard to ensure the long-term sustainability through all of these changes anticipated in the years ahead. So with that, I'm going to dive in to share a little bit more about exactly what these changes look like on the eligibility side. I think one of the biggest misconceptions or areas of confusion is who this impacts, what is actually changing. And so what I like to start with whenever I talk about HR 1 is really clarifying who is exempt. For the following people, nothing about their Medicaid coverage is going to change in the coming years based on this federal legislation. Those groups include children, seniors, pregnant individuals, people with disabilities, and parents of children that are under age 13. So if folks, that's the majority of our Medicaid population, if that is the category that folks are eligible for health coverage in, nothing is changing on that front. The focus of these changes are specifically for what's called our adult expansion population. Those folks are adults ages 19 to 64. They cannot be caregivers for young children. And importantly, there's about 147,000 people in our state that fall into this category. The changes I'm going to talk about shortly, work and community engagement requirements, 6-month redeterminations, and cost sharing all apply only to that group. So again, a very specific part of our population. So if you move to the next slide, I like to visualize this or talk about it like a bit of a funnel. So we start at the top with our total Medicaid population, which is just under 800,000 people. Of that overall program, about 270,000 people fall within our adult expansion population. The way federal legislation is written, not every single one of those people will need to meet work and community engagement requirements, though. So further down the funnel, we have the population that actually will be required to meet those work requirements, and that's about 147,000 people. Most importantly, there's still that tip of the funnel or tip of the triangle, and those are the people that we actually need to request documentation from when they're applying for Medicaid or renewing their coverage. And notably, we're working hard to make that tip of the triangle as small as possible, using data that we have to demonstrate that people are either exempt or already compliant with these requirements. Importantly, about 2/3 of adults in this population are already working. So we expect for those people, this may be an exercise primarily in submitting documentation if we don't already have it. For the other third of adults in that population, it will be an exercise of noting whether they are compliant through a variety of different mechanisms, which I'll talk about in a second. Before we get there, though, I want to share a little bit more about the timeline. So as we all know, this piece of federal legislation was signed on July 4th, 2025. We've been hard at work since then to prepare for implementation. I will note we're expecting formal guidance and regulation from our federal partners in June of this year. It's a really lengthy process. I know that they've been working quite hard to pull that together, but we can't wait until June to begin this work. And so we've been moving forward with our implementation based on everything we know and more informal guidance that CMS has given. And we expect our efforts to align with that formal guidance we'll get in just about a month. We had our first public workshop on these changes and getting public feedback on them in March of this year. We will continue those at least quarterly through the rest of 2026 and likely into 2027. We're really committed to hearing feedback from our community and also hearing what's going well and where there may be challenges. And we recognize as this significant change is unfolding, we need to hear directly from people and hear from them frequently. So that's the intention of those public workshops. What we're moving towards, the big date on that timeline, is January 1st, 2027. That is when anyone who is applying for Medicaid in that adult population will have to meet work or community engagement requirements or be exempt in order to enroll in the program. Also, after that time, anyone in that 147,000 estimated population that renews their Medicaid coverage will also go through that same process. I'm going to talk about this a bit later, but the 6-month redetermination change, basically changing how frequently people renew their health coverage, that also goes into effect in January. And then there's a couple other changes that I'll note. In October of this year, there's a few changes related to immigration status and who's eligible for Medicaid. And then in 2028, fall 2028, is when our cost sharing provisions take effect. You'll note, I'll share a little bit more about that in a couple slides, but there's not going to be as much time on this particular component of the presentation, given that we are awaiting our first federal guidance on that piece, and there's not as much detail in HR 1 on what that will look like. So we'll have a lot more conversation and public workshop on that piece at a later date. So with that, let's move into those exemptions like I've talked about. So this is an area of policy decision that the state will have within broader federal guidelines. So I'll talk about those exemptions a little bit more, but generally the federally mandated exemptions fall into 3 categories. People can be exempt based on who they are. So like I mentioned, children and youth, seniors, tribal members, people who also are enrolled in Medicare. You can also be exempt based on your health needs. The way that's described in federal legislation is medically frail. I think what we would refer to more generally is someone who is unable to meet the requirements due to their health needs. The last piece is someone may be exempt based on their situation. So people that are caregivers, people that may be recently leaving incarceration. There's a number of requirements outlined in federal law that would exempt people from that program. I'll talk about this in a couple more slides, but there is a 4th category that states can opt in if they would like to select related to short-term hardships. So the high level is, of that bucket, the reason it goes from 220,000 people to 147,000 people is because we're removing those that are federally exempt from those requirements. So if you move to the next slide, this is kind of a summary of, again, what those requirements actually are. So once we know who is eligible, who is exempt, what do they actually have to do? So like I talked about, work and community engagements is probably the one people are most focused on, and I'll share a little bit more about what actually counts for that in a second. The second piece is 6-month eligibility redetermination. So the same group of people, instead of renewing their Medicaid coverage every 12 months, will renew it every 6 months. So this is a more frequent cycle of renewal. The last piece, as I mentioned, is cost sharing or co-pays. Currently in our Medicaid program, no services or providers have a copay associated. It's free of charge to members. So this is a change in federal law. States will be required to collect copays from this particular population for a particular set of services. The details of which I mentioned, we're still awaiting federal guidance on. So I think this one is a little bit more nebulous as we await further clarification from our partners at the Centers for Medicare and Medicaid Services. So diving into the definition of work and community engagement, I think what's important is it's not just work requirements. We recognize that there's a range of activities Nevadans are doing right now that count towards engagement with their community. I was really excited to hear during public comment, SafeNest's commitment to volunteer hours. Those exactly are what would count for these types of requirements. Fundamentally, people have to meet 2 thresholds. Either they're completing 80 hours per month of a qualifying activity, or they're earning at least $580 a month. We recognize Nevada's employment landscape is unique. There is a lot of seasonal work, there is a lot of shift work. And so what we're continuing to do in our work with CMS is determine what flexibilities we have to collect and document information on all different types of employment to ensure that all of the activities that folks are doing is clearly captured and documented. So on the slide, we talked about, again, employment obviously counts. Job training, such as apprenticeships, are also considered part of those work activities. Community service, as I mentioned, counts as well. School, so being part of education, is a qualifying activity. And it seems that CMS is accepting a pretty wide range of kind of educational levels in that definition, but that's one of the components we're awaiting further federal guidance on. Self-employment and seasonal work both do count. There's been a lot of discussion on how those are calculated and how do you ensure that they're accurately reflected at the time of renewal or application for Medicaid. So trust that there's a lot of detail that goes into how we calculate those, and the intention from our federal and, of course, our own state policy decision is to ensure that folks' seasonal work and schedules are reflected accordingly. So the next question is, how do we verify compliance? These are the activities that you can complete. How do we verify it? First and foremost, we will do everything we can to use current and new sources of data to validate it without ever asking members for more information. So we've done a really comprehensive data review, and this is ongoing with a number of our sister agencies to get data on wage and employment history from DETR and other agencies that are collecting that already. We're working to collect education data from our partners that already have that. And so our intention is to ensure that anything that the state has access to that we're able to connect our data systems to, which I'm deeply grateful for our IT teams that have been hard at work since last year to really do this analysis and figure out what we can do from a technological perspective, will be to determine folks are automatically compliant or exempt without asking for more information. If we do, though, this will be done at the time of renewal or at the time of application. There will be a screening form that folks can complete and essentially attest to the fact that they've met these requirements, and that will be audited throughout the time that they're part of the program. And there will be essentially these exemptions that they can also attest to as well. So either that they meet requirements or that they're exempt, there'll be different paperwork for that piece. And again, this follows the federal guidance there and is really intended to be as comprehensive as possible while limiting the outreach that we're going to do. I'll talk in a couple slides about the patient outreach that we're planning. I'll note, I think this is one of the most important times that we've been communicating with Medicaid members, and we'll continue to do so. We're deploying a similar playbook like we did during the unwinding when we had to redetermine a lot of people after COVID. But I think there's a lot that we learned from that we'll continue to improve, and I'm excited to work with our community partners to really get the word out. So before we move into that timeline and kind of path ahead, I do want to talk about 4 key decision points that we have as a state. As I mentioned, the federal law and the guidance from CMS is fairly prescriptive. All Medicaid programs in the country that have to implement these work requirements are doing so in a pretty similar way. But there's 4 areas where we do have flexibility as a state to make some decisions. And this is what we shared at our public workshop about a month and a half ago, and what we'd love feedback on from the committee today. And from any others that are listening and weren't able to join our public workshop, we'd love to hear from you. Our public comment period is open until April 30th, so nearly the end of this week. And what you'll see in the next slides is reflecting the feedback that we've gotten so far. So those 4 decision points we have are whether we should offer a short-term hardship exemption, which I talked about earlier, determining what our look-back period is for compliance. How long will people have to meet work requirements to be compliant with the program? How do we transition to 6-month redeterminations? And then lastly, and very importantly, how do we define medically frail? I'll ask you all to kind of buckle up and bear with me as we get a little bit wonky in Medicaid policy in this, but I think it's really important that you all see the kind of thought and preparation we're going through in making these decisions. And we really do want input on how to do this right for Nevadans. So I'm happy to take any questions at the end if any of this remains unclear. So as I mentioned, that first decision point is related to short-term hardships. So this would be the 4th kind of exemption point in addition to those ones I already mentioned. And it would allow for people that are experiencing disasters, hospitalization, having to travel a long way to receive healthcare, or living in a high unemployment county from being exempt from work and community engagement requirements. This would essentially allow people to protect their Medicaid coverage while they're experiencing what we believe to be a short-term and somewhat unexpected event. States have an option to utilize that exemption, or they can choose not to and stick with the 3 federally required exemptions. Our recommendation is that we do include this 4th category. This is because it aligns with our commitment to member access to coverage and avoiding disruption and continuity of care. We also recognize that one of Nevada's unique aspects is how far people do often have to travel for care, especially in our rural and frontier communities. We believe this better aligns with our goals of ensuring people have access to high quality care and can maintain that access. The feedback we've gotten so far, it's at the bottom of the slide in smaller font, but has been aligned with that approach. People had offered suggestions to expand that definition more broadly. Our understanding, and we'll see what that guidance looks like in June, but it's pretty prescriptive in federal guidance. So we don't believe we can expand it further, but the feedback we received was strongly in favor of that option B, which would be to accept that 4th exemption. We move to the next slide, you'll see this is where things do get a little wonky. We have to do some math, but it's an important, really crucial piece of this program implementation. So states have an option of how far back we look to determine that people have been compliant with work and community engagement requirements when they apply or when they renew. So as I mentioned, this happens twice. First, when you apply to Medicaid the first time. Say I'm applying in April of 2027, I would have to demonstrate either that I was compliant with work requirements in March of that year or in January, February, and March of that year to be compliant for Medicaid. So states essentially can pick between 1 and 3 months of look back when determining eligibility. Our recommendation is to do a 1-month look back. So if I was applying in April, I would need to demonstrate compliance in the month of March. That's because we believe it's better aligned with what people's current activities are. It minimizes the reporting burden for members for how much data essentially they'd have to submit, and it helps the state's administrative burden in processing all of that information as well. The second time compliance is checked is when you renew your Medicaid coverage. So if I'm renewing my coverage, I'm currently a Medicaid member, I'm renewing my coverage in August of 2027, I would have to demonstrate that I was compliant with work and community engagement requirements either in any month of 2027 or in February, March, April, May, June, and July. So those are kind of, and then kind of any option within that. So states essentially can pick between 1 and 6 months look back during an active coverage period. Our recommendation is that we would accept compliance with work requirements any one of the 6 months before you renew coverage. That's similar. It again minimizes administrative burden on our staff and our kind of intake process. It also allows people to not have to assemble 6 months worth of information when submitting documentation if they need to do so. And so again, our recommendation was that 1-month look back. Community feedback has been generally in favor of both of those approaches. Again, in alignment with Nevada's commitment to ensuring access to high quality care, as well as trying to ensure the state can implement these requirements as efficiently as possible and minimize staff burden throughout that process, we would recommend this approach. Bear with me, that was the second of 4. So move into decision point number 3. This is an option that states were given based on guidance from CMS that came to Medicaid directors just a couple weeks ago about how states will transition to a 6-month renewal cycle. So like I mentioned, every person on Medicaid right now goes through an annual renewal cycle. So every 12 months, they have to submit information to demonstrate that they're still eligible for the program. The adults in that population that are not exempt, that will now move to every 6 months. And so states have 2 options on how to do that. Either option A is you reschedule everyone's current redetermination dates to early 2027 to say, regardless of whether you're scheduled to be renewed at any month in 2027, everyone will be renewed in the months of January, February, or March, or whatever state decision makes. The other option is keep everyone's redetermination dates as they are right now. If they are still Medicaid eligible and they meet work requirements, then it moves to 6 months after that time. In either option, we are federally required to provide notice to people in advance of that redetermination, and they, of course, have an opportunity to appeal if they do not meet those requirements off the bat. Our recommendation is to go with option B, primarily because it's a really complex process to reschedule a lot of people's redetermination dates in a system that we're already working very hard to update and to edit in reflection of this new guidance. And so our recommendation is to keep the dates for 2027 that are already scheduled and will be already scheduled in an effort to really spread this out throughout the year, avoid burdening our state systems, and helping us to learn quickly. If there's things that we can improve in our systems and our process early in 2027, we want to do that right away in order to reflect those updates to the process as soon as we can. Feedback on that point has been similar. I think the general public consensus has been option B on that one as well. The last piece is the definition of medically frail. Again, that's the term in federal law that would exempt people from having to meet these requirements in the first place. In the left, and I'll read these here, I think it's important for you all to hear, this is what every state is required to include in their definition. So people with significant physical, intellectual, or developmental disabilities, people with disabling mental health disorders, people with substance use disorder, people with serious or complex medical conditions, and people currently receiving treatment for substance use or other serious health conditions. As you're reading that list, you can probably appreciate there's a lot of variation, or those are pretty broad categories. And in our world, every broad category has about 1,000 different medical codes and diagnoses. And so every state has the opportunity to really define specifically what does that mean for the state's definition, and how do you translate that to diagnoses and to codes that we would then process in our system. You can find our draft definition of medical frailty on our website right now. This is what we shared with our stakeholders in our public workshop and over a number of our listservs and website over the past month and a half. It's a very comprehensive definition that we believe aligns with federal law and will allow us to really clearly determine whether someone would be medically frail. Community feedback has supported this definition. We've gotten a lot of feedback on specific conditions that folks would recommend to be included. We are evaluating each of those to determine how they align with federal law. And we're really grateful for that feedback and would welcome that in our final days of this public comment period. As I mentioned, members will have an opportunity to self-declare a definition of medically frail if, for example, they recently moved to Nevada and we don't have any of their claims history. We can't already determine that someone has cancer, but they can self-identify that they are experiencing that condition. They would be exempt from work requirements, and we would audit that in the coming 6 months once they are able to see a doctor in our state in that particular example. So, all of those policy decisions covered here, I want to walk you through what happens next. We are collecting feedback on our policy implementation of this process. Again, that closes on April 30th. We will share our final decisions in a public workshop that we're currently slated for early June. We'll have an exact date for you all very soon. From there, our focus really shifts to how do we communicate about this and how do we leverage our community partners. There is a ton of work that I'm really excited that our teams have been thinking about and working on since well into last year on how do we apply some really creative new approaches. We have funding for our new Navigator program that was approved during the special legislative session last fall and those navigators will be trained to really support people to walk through that process. And if they don't meet work requirements, to help them select a plan that they are eligible for. We're also going to be developing a lot of public-facing content. So social media content, flyers, other ways to really try to get the word out. We recognize the state has plenty of channels that we can and will use, but really the trusted voices for our patients are community organizations and providers and other groups in our communities. So we're going to be doing a lot of work to meet with them directly, equip them with the information that they need to be able to have the conversations that I recognize people are asking questions on today, and they need the information to kind of help folks through that process. So know that this will be a top priority for us through 2026. I'm really excited about what it means in terms of the ways that we can really continue to be creative and modern in the way that we communicate with our members, meeting them where they are with whatever technology and tools that they feel most comfortable in as we prepare for the go live in January of this year. Again, those public workshops will continue, and we look forward to your feedback in that forum, and of course, happy to answer any questions on that piece. Before I turn it over to Stacy, I do want to touch on one other component of our federal changes to our program. And again, for this one, I'll ask that you kind of step outside that funnel view. This is not specific to adults in that expansion population. It's applicable more generally. And this is related to Medicaid coverage of lawful immigrants on our program. So the federal law has changed. So certain categories of lawful immigrants that previously had an ability to receive Medicaid coverage based on a current status and after a current period of time, those people will no longer be eligible for the Medicaid program. There's a lot of detail here on the process, but I want to be very clear on the people that will remain eligible. Those are lawful permanent residents, Cuban and Haitian entrants, and COFA migrants, or lawfully residing children or pregnant women that qualify for what's determined as a CHIPRA option. We expect about 5,000 people to lose their Medicaid coverage in Nevada if they are not determined to fall within a different immigration category when we re-verify their status. So this summer, all states will have to re-verify which immigration status a beneficiary is part of and determine whether that's part of a satisfactory category based on the new federal rules. If they are, we will send notification and let them know that they are part of a new Medicaid eligibility category. If they are not, we will provide advance notice, written notice with information on where to submit documentation if they believe that's not an accurate determination and how to appeal that notice as well. That will happen late summer in preparation for October 1st, which is when those federal provisions hit. Again, as I mentioned, there is a 90-day period after which people can always appeal their Medicaid decisions, and so that will be happening through the end of this year. The next slide just kind of talks about that noticing piece. Again, we're really committed to being as transparent and clear with members as we can as we implement these federally required changes to the program overall, and we'll continue to provide transparency in terms of the actual number and population size as we move through that process. So with that, that is my summary on the eligibility category. As I mentioned, the second really specific impact for Nevada from HR1 is on our hospital provider tax program. And I'll turn it over to Stacy to talk about that.
Madam Chair, Stacy Weeks for the record. I wanted to see, Chair, if you wanted us to stop for questions or keep going, because I know we got a lot here.
Thank you. I appreciate that. If you'll go through the rest of your presentation and then we'll stop for questions.
Oh, sounds good. You got it. Stacy Weeks for the record, Director of Nevada Health Authority. I'm going to try to drive my slides here and talk. So real quick, like Ann mentioned, when we look at just big picture for Medicaid, and again, it's eligibility and then it's provider tax changes that are really impacting Nevada. Now, some states have different impacts depending on their programs. So we're talking about Nevada here today. So there are three ways that our tax programs are impacted. The first is that there's a moratorium on states now that has gone into effect. I think it goes into effect completely last October. For provider taxes. So no new state Medicaid provider taxes, which reduces our ability to generate revenue for our program. One of the reasons states like provider taxes or provider fees is because it generates the state's share of the program. We use that to match. And providers often, if they're getting a rate increase, for example, from that or supplemental payments, they also sometimes like the program. Not all of them, but most of them. So states all across the country use their provider tax revenue differently. And I want to talk today about how Nevada uses it. And so when you're looking at national publications, you have to be very mindful that they don't understand how we use our provider tax revenue. A lot of states use it to replace state general fund. We do not primarily use it that way. And so we'll talk more about that in a minute. And that's why some of the numbers, like in the RAND study, we'll talk about in a minute, is not accurate. And we've reached out to them and still waiting to get a conversation. The second item here that has happened is that it lowers our ability to collect a percentage of total revenue. Right now, we collect approximately about 6%, for example, on total patient revenues minus Medicare from our hospitals, our private hospitals. We will have to reduce that over the coming years down to 3.5%. So that reduces how much revenue we can collect, which also reduces how much we can match, which reduces the output. So we'll talk a minute about there are multiple ways that impacts the budget, and we'll walk through that. The third thing that happens here is that when we collect that revenue, for example, for our hospital tax program, we supplement the base rate. So you'll hear later from the Hospital Association about their rates, and they're very low, but we supplement those payments up to Medicare UPL with the provider tax program. And then on the managed care side, any claims that come in, we supplement up to average commercial rate today. It's a big, big piece of the money, and it's driving the program. The new federal statute says that they have to lower that down to what we call generally Medicare rates. It's not the same as Medicare UPL, so we're waiting for guidance to figure out how are they going to define that, because not everything we cover in Medicaid is applicable or the same in Medicare, right? They don't often cover all the services. Medicare can be limited to a certain population, which is typically seniors. So we're waiting for more guidance in this space. Until then, it's really hard for us to really we're kind of throwing a dart, right, at what we think the impact will be, depending on how much more we can supplement managed care claims. So we're working closely with Mercer on all of those pieces. And again, like Ann said, we're hoping for guidance this summer, and we're waiting anxiously for that. I think every state is right now. So let's look at the timeline here. So HR 1 there were different iterations, when the bill was passing, and some were super fast. And this at the end, they landed with, we're going to phase this in, right? We don't want to, it's like a whiplash, but we're going to take it over a couple of years, essentially. So the moratorium goes into effect, this October, and then October 2027, we start to reduce the rate down. So we are collecting less. I do want to note that our skilled nursing facility tax program is our second tax program. They are exempt under HR 1. They clearly had a great lobby at the federal level. They're the only ones that were exempt from provider tax changes. So skilled nursing facility tax remains the same under federal law. Any new taxes, like I mentioned, moratorium. So like, for example, EMS passed last session. We'll talk about that in a minute, how that's impacted. But the only other tax we have is our hospital tax. So right now we're looking at how do we start to phase that over this timeline, reducing that rate, but also applying the new Medicare rate cap for the managed care side in October of 2028. So all of these things kind of compound over time. And by the end of 2031, we'll be down to a 3.5%. When it comes to the tax program, just to kind of remind everyone, there's always winners and losers in a tax provider payment program. There's no such thing as everyone being a winner. And that's why we always have a couple angry, unhappy people, and then a lot of really happy people. And that's part of the deal with a tax program. So I think the key we're watching as we phase down is what happens to hospitals? Are we going to have more losers than winners? And what does that mean for the viability of the program? So we're going to be, once we get formal guidance, we can start to do some modeling around that with Mercer. All right, so before I dive into the budget impact, I did want to note real quick, let's not forget HR 1 did impact our Nevada Health Link. So under the Nevada Health Authority, we do have our state exchange. And so I just want to point out that a lot of the folks moving off of Medicaid, the adult population that may not qualify any longer for work requirements, there are some new restrictions for them as well as immigrants in our exchange. And so we wanted to add this slide here today to make sure that doesn't get lost in this conversation, because there are some activities that our exchange needs to do to try to ensure continuity of coverage and that people are getting information on resources to how they can get coverage. So just here on the slide are a couple things that are changing, but as you guys recall, our private market, we had these COVID era enhanced subsidies helping buy down premiums in addition to what was already in the exchange as a subsidy. Those have expired, right? And so that was for this open enrollment period. We still saw a pretty steady enrollment, which was good. But then there's all these new things that are going to be added on over time. And they're all listed here. I think the one I really wanted to point out is that anyone who is ineligible for work requirements cannot access premium subsidies through the exchange. So if they're determined determined ineligible, they go to the exchange, they cannot find the reduced cost coverage. So that is going to be a challenge. It's something we're working through. I think all states are looking at waiting for formal guidance on what they can and can't do. One thought is you could do state subsidies, you could do additional things, but you just have to remember implementing things like that through the exchange can be complicated when you're doing just a state subsidy. But there are some solutions. But again, we're really waiting on some more guidance from CMS on all of these pieces. All right, let's dive into my favorite topic for a policy committee is budget. So my apologies. I am going to do a little quick grounding on the Medicaid budget because it's really important to understand so you can understand how the tax program is a budget and it's not a budget impact. So we'll talk about why that can be true all at the same time. So some of you may recall, if you've been in part of these conversations before, total Medicaid spending in our budget, which is about $15 billion for this biennium, is made up of federal and state money, or state share and federal share. Federal share, generally speaking, is roughly 60% in Nevada, and state share, we'll talk about what can be made up of the state share, but state share is generally 40% of the cost. So you can kind of slice it that way, generally speaking. About 3% of this spending goes to administrative costs and operational spending. And then 97% goes to what we consider paying for the cost of healthcare services and delivery. 90%, we do get some 90% match, and that's for that adult expansion population I mentioned earlier, which impacts budget. And then we also do additionally get 90% and 75% match for IT. So there's different ways to look at the match, but it is a shared program with the federal government. So just like I mentioned, there are limited ways that we can make up the state share. There's the local county government, for example, funds that we can take in through interlocal agreements. We can also use, obviously, state general fund, which is made up, it doesn't come out of thin air, right? It comes from tax revenues. And so those tax revenues can be used. And then there are other ways that we can offset, like I mentioned, is that provider tax revenue. So by taking that off the table, that does impact our budget, or by reducing it, it does impact the budget. And there's some other pieces here that we look at in Medicaid. The last one there, pharmacy rebate revenues, is the big one that has been really generating a lot of revenue for us. So like I mentioned, state budget impact, depending on the state, the impact on the provider tax program can be a make it or break it for your budget. It depends on how you were using the revenue. It's really key to remember that. All right, so I think when I made this slide, it made sense. So let me see if I can remember. It's a little complicated. So like I mentioned, there are several taxes that we have in the state that are impacted the HR1. So like I mentioned, private hospital tax has the most changes to the program. Our EMS tax, as it was passed, there are potential changes to that program because when the modeling was done last session, we weren't sure where were we going to land. And there were some conversations about what do we do? So the modeling around that, we were assuming a 6% tax rate, right? So now that program will change because it will be reduced under the new law. Like I mentioned, nursing facilities are exempt. And then let's not forget our premium tax. And I'll talk about in a minute, but it is impacted by our private hospital tax program. And I'll talk about that soon too. And then, like I mentioned, the tax revenue is reduced. You can see there. And then every tax except for the nursing facility, and then state budget impact, which tax has an impact because of this. Private hospital, yes, when it comes to children's behavioral health, because we use that fund to offset state general fund. So that is the reason the children's behavioral health fund will be reduced from the changes. And then the second piece here is our premium tax. So in Nevada, the state taxes all insurance payments. And the big one is through the Medicaid managed care program. The private hospital tax payments, a big portion of them run through the managed care program. So when you lower those, you reduce how much revenue, right, you can collect. So we're going to be reducing how much revenue is coming through by lowering the tax revenue and the match. That ends up meaning less in premium tax collection for the state general fund. So just throwing that out there. We do have some early projections on that, but again, it just all depends on the summer guidance. All right, sorry, hopefully everyone's still with me. But when we looked at guidance and what we're trying to put out right now is a real, I would say, a guesstimate, and trying to put out more of a range because depending on the guidance, we could be high or low. But right now we're looking at the following. So the private hospital tax, like I mentioned, it can be used to supplement what we do today in the state, supplement our state general fund for supplementing hospital reimbursement. It does not replace or supplant state general fund for hospital payments. It does supplant and replace state general fund for children's behavioral health. So there are some losses in general fund in that sense. HR 1, specifically, we're thinking it looks like 25.5 million to 30.5 million loss for our Medicaid budget when it comes to children's behavioral health services and Medicaid. Now, we are still going to be collecting about 88 million to 93 million still to support children's behavioral health. And that's unmatched. I want to be clear. So when you match that, it's still a big portion of money. It's over $100 million at least a year or more, depending on how we match and what services. So the bad news is we are losing $25 to $30 million for children's behavioral health. But like I mentioned, the tax program, if it's still in existence, is still producing close to $100 million for the state. When it comes to the hospital pieces, we'll talk about that here in a second. But I would just say that we do estimate that the supplemental payments hospitals receive today, that they'll be reduced down by $600 to $800 million per year. That is not a state budget impact because those did not replace or supplant general funds. Those were in addition to what they were getting from our state as of like 2 to 3 years ago. So this is just like, I like to consider the provider tax payment program like cherry on top for them. We just removed the cherry and it wasn't state funded. Okay. Not to say that that doesn't have an impact, and we'll talk about that in a minute on the healthcare system, but it does not have a direct impact to the state budget. On the premium tax side, we do have a situation where we are supplanting some state share using premium tax. Like I mentioned, the premium tax is applied to our managed care payments, which is billions of dollars every year. We tax that, we match that, and that generates good revenue for the state general fund. That will be reduced because we're reducing the payments that are going to hospitals now through the managed care plans because the tax program is being reduced. We estimate that that's about $66 to $79 million in state general fund revenue that we might have been projecting for this biennium or upcoming biennium. And all of these numbers we are sharing with the governor's finance office. We've also sent them over to LCB fiscal. But again, we're waiting for guidance to really narrow down that range. All right, let's dive in a little bit for the bigger picture. Let's not forget that coverage is important, right? Regardless of the state budget, there's still an impact when it comes to uncompensated care is a big one for our healthcare system, not just for our hospitals, but for our safety net providers like our FQHCs. And Ann mentioned earlier, originally we were talking somewhere between 100 and 200,000 people would be impacted by work requirements and community engagement. Because of the federal guidance and what some of the choices we've been able to already kind of make with some of the public feedback is that we're thinking we can narrow that down, like Ann mentioned, to 147,000, but possibly even more with some of those hardship exemptions. Because imagine that there's so many counties that, for example, people that live in counties that have no jobs, right? We think a lot of people could be exempt for that too. So that number could get even more narrow because Ann's nice triangle slide where we narrowed it down like a funnel. We're hoping to really narrow that down with more decision points. And also to remember, once we lose folks that are covered, that affects our uninsured rate. So looking at this range, it could impact our uninsured rate, right? We could actually go down or go up, increase anywhere from 15 to 18%. So right now we're currently 11.4. We're expecting it could go up to 15% on the low end if it's at 100,000. If we end up getting more people lose coverage because of paperwork and the process, it could go up. Our uninsured rate could go up to as much as 18% in Nevada by 2028. So it's important that we give you the range because it's really hard right now to know. And so right now, just to remind everyone, there are still today 367,000 people uninsured, right? And so that's a big bucket, and this would be adding to that bucket. But like Ann mentioned, we're trying to do a lot of things in this space to try to reduce that down and to help get people connected to services, including employment. The other piece that we're looking at is how do we address some of the increase in cost to emergency room visits? Uninsurance often leads to more emergency costs, delayed care, which grows costs in our Medicaid program, and healthcare costs in our state. And it's a real strain, and we all know this, on our safety net providers. And so that's something we're acutely aware of and looking at strategies and trying to think through what can we do to support them. But as you guys know, we have limited funds. So some of those strategies may need to come from next session. Population health is also something we have to think about. When you think of the number of people impacted by HR1 and how much Medicaid plays into our healthcare system, there is an impact on our ecosystem and the healthcare system. Like I mentioned, 600 to, it should be 800 million, sorry, it says 600 to 800 million in losses for our state's private hospitals. That will have an impact on their operations, period. It's important to remember, though, in 2028 and 2029, they're still getting over $2 billion in that provider tax program. So it's still money on the table. It's just less money. It's less cherry on top, if that makes sense. But that does impact our system. They, for the last 2 to 3 years, have relied on that funding, relied on that increase, that cherry on top, and now they can't. And that may change some of their decisions for growth and for outreach and all the things that they're doing that we do want them to be doing, right? And like I mentioned, population health will be impacted. We also know that people end up using the ER more. They delay their medical care. I have here some examples from Arkansas. Arkansas did see about 56% of people that were impacted and uninsured with work requirements delayed medical care. 64% delayed their use of medications. And they also noted that they were concerned about increased risk of chronic illness in the affected population. So it's something we need to be watching very carefully as this rolls out. And then indirectly, there are always indirect economic impacts when hospitals lose funding and systems of care. Job losses in the healthcare system is something we need to be mindful of. At the same time, we're trying to attract workforce, right? So it's sort of a challenge that we need to think through as a state. Also, it puts more strain on our public health partners, right? They're already feeling some strain, but we have to think through access to preventative care and primary care is really essential to really controlling costs in our state. And how do we do that if we're losing access to coverage? And then medical debt is another piece I wanted to mention. In Arkansas, they saw medical debt for this population increase by 50%. Now, Arkansas did not have some of the hardship exemptions in place that we are looking at applying. So we're hopeful that some of that, again, like I mentioned, we can really narrow down the population and help those that are affected get employed quickly. All right, I promise I'm almost there. So how do we address upcoming challenges? There's a lot that needs to be done. It can't all come from the state. I think we have limited resources. We're going to have to rely a lot on our private partners as well. A big one, though, that I want to kind of end on a positive note, because I know it's a lot for the day, is that we did get a lot of funding, $180 million from our Rural Health Transformation Grant. As a reminder, this amendment that was added to the bill was really in recognition of the hospital impact from the provider tax programs. States like Texas, Florida, I want to say Washington too, they've had some historic provider tax programs around much longer than ours. And they were using these to not only supplement rates, but sometimes offset state general fund. So a big piece, Senator Murkowski in Alaska really fought to get some rural health funding. And so that's where this grant comes from. And as we're rolling it out, we're really mindful of that and making sure that hospitals in our rural areas are really engaged on where these funds go, because if they're not really supporting that system, it's not the intent. It's not going to the intent of the grant. We're also looking at, like Ann mentioned, a lot of outreach and education, trying to think through some more marketing and really more technology and how we reach our recipients. Our Navigator program, thanks to lawmakers here today that put that into place, some funding for that program. We are looking with our exchange to really roll that out to support Medicaid enrollment and address some of these work requirement pieces. And then some of the things we were already doing at Nevada Health Authority is we're looking at our purchasing strategy. We just brought on Milliman to be working to put together a purchasing strategy for the state around healthcare. A big piece is value-based care, which I know some of you are interested in. That is the best way we can remove barriers to care and really reward our systems for primary care and prevention. And then looking with our public health partners, how do we manage population health better in the state? And then last but not least is like a new kind of partnership, I would say, between us and Medicaid and our employment supports and resources at the state level, as well as even broadly with private employers. How are we getting helping people get jobs so they don't have loss of coverage and continuity? And now I'm going to turn it over to Melinda Southard in Carson City so she can walk through the great work that she's been doing on the Rural Health Transformation Grant. Thanks, Melinda.
Thanks, Stacy. Madam Chair, members of the committee, good morning. My name is Melinda Southard. I serve as a Deputy Director for the Nevada Health Authority. Oh, is it not on? Is that better? Nope. I'm going to move. Good morning, Madam Chair, members of the committee. My name is Melinda Southard, and I serve as Deputy Director for the Nevada Health Authority for Community Engagement and Workforce Development. Thank you so much for allowing us to present these slides today. Wanted to talk a little bit more about the Rural Health Transformation Program. Oh dear. Apologies, folks. Oh, nope. Okay, good morning. Apologies. All right, so the Rural Health Transformation Grant, we were awarded as a state $179,931,608 and, very importantly, 42 cents. This grant application, we submitted 4 primary initiatives that we wanted to focus on that I will go over here. I want to note that this grant program is for a period of 5 years, and each year the state is awarded approximately around the same amount. It can go up or down depending upon how the state meets the goals and objectives that we put forward in our application. So for this first box here, this is the Rural Health Outcomes Accelerator Program. This is one of our primary initiatives. We have, in this first budget period, we have almost $27 million allocated towards this initiative to help to fund evidence-based initiatives intended to improve rural health outcomes, particularly in the areas of chronic disease, primary care and prevention, maternal and infant health, and of course behavioral health. We will have a request for application which will result in subawards available in May of this year, and we estimate that the awards will be announced in summer of 2026. Next, we have the Rural Health Innovation and Technology Initiative. This also is another on nearly $27 million intended to fund innovation and technology solutions that fill gaps in healthcare services in rural Nevada. So this is a targeted investment towards aligning with the CMS health technology ecosystem and additional, obviously, of course, including interoperability between health systems. We intend to have these funds available through an RFP, which is a request for proposals that would result in contracts available in May, so early May. We are working on finalizing these documents at this moment and anticipate, again, awards in summer of this year. Next, we have the Workforce Recruitment and Rural Access Program. This is where we allocated a majority of the funds each year of the Rural Health Transformation Grant due to the high need, of course, in Nevada for healthcare workforce. We have $71.9 million allocated in this initiative to attract and retain physicians, including a wide variety of other provider types, to rural areas and frontier areas. That include recruitment and retention strategies, training and apprenticeships, and rural workforce programs. We do have 2 RFAs that are currently open. Those are for recruitment and retention and training and apprenticeship. Those are due, or the deadline is May 15th to apply for those. We will have an additional RFA available under this initiative for rural workforce programs that we anticipate coming out early May, and we will have awards announced for all of these again in summer. Lastly, we have the Rural Health Flex Fund grant program. This is almost $36 million to fund capital expenditures and infrastructure costs that help to, enhance and modernize local, rural, and frontier healthcare infrastructure. This is as an RFA. It was released in March, and the deadline is in a couple of days. So deadline to apply for this Flex Fund program is April 30th. And we anticipate announcing those awards in May. And again, with these funds for this first budget period, we have to have everything obligated by October 30th of 2026. So obligated means that it has to be obligated in a subaward or a contract or, another formal notice of obligation of those funds. And then we have to have it liquidated or fully spent no later than September 30th of 2027. And this is so that CMS has the opportunity to take any of those unobligated funds and redistribute it to states in the next budget period. If we go to the next slide. So the Rural Health Transformation Funds, of course, a primary initiative or goal of this is to truly benefit our rural and frontier healthcare systems. And this is really the heart of everything that we've, put forward in the Rural Health Transformation Program to date. In Nevada, we're doing it a little bit different than other states. We are, asking that the rural and frontier communities come to us with what they need most, what will benefit them the most, and have those vendors and other contractors and providers to work with the local rural and frontier communities on what works best for that community. It's definitely not a state dictated process. It's more grassroots effort, and I think that's really important for our state. Additionally, the the RHT awards and programming must include a sustainability plan that, obviously does not solely rely on new state general fund approval. And so that was another really important thing that we wanted to put forward in this program, that, everybody that's applying for these funds must have a sustainability plan built in of how they're going to carry forward this program once the grant ends. In the next slide, we go over the Rural Health Transformation Steering Committee. So in our grant application, we put forward a list of 15 members that includes a broad array of representatives from rural and frontier health systems and communities within our state, plus state, local, and tribal health representatives. We had our first meeting on March 11th, and I'm happy to say it was a huge success. We did receive a lot of feedback that we were able to incorporate into how we release the RFAs and pending RFPs for each of these initiatives. It was really helpful feedback from the steering committee members. The steering committee is not involved in making specific funding decisions related to how the RHT funds are spent or who they're awarded to. However, they do track progress on all of the initiatives and can recommend adjustments, to change course or align with some best practices or what is working better in, in our state or another state, and make those recommendations. Our next meeting for this steering committee is on June 9th. These meetings will be held quarterly, and they are open public meetings, so anybody is welcome to join and attend. And then lastly, I just wanted to touch quickly on community engagement and outreach with the Rural Health Transformation Program. As I mentioned, June 9th is our upcoming meeting of the steering committee. Also today, we actually have a Rural Health Innovation and Technology pre-RFP webinar. So it's going to provide some important information about the health IT functionalities and capabilities that we may speak to in the RFP that will be released early May. And if you're unable to join that webinar, we will have that recording available on our website along with the slide deck. And yesterday we had another webinar along those same lines talking about the CMS health ecosystem. And this was a really important, informational webinar because we talk about this health IT ecosystem, but really what does that mean? And so this webinar went into the details of what that is and what it means to be aligned with that. And then lastly, we just recently had a workforce recruitment and rural access program webinar for interested applicants in the 2 open RFAs that we have right now. Again, that was recruitment and retention and training and apprenticeship. And then lastly on this slide, we did include some online links to our Rural Health Transformation webpage. We try to be very transparent and put everything we possibly can on our webpage. We even have our notice of award on our webpage so that folks can see exactly what Nevada was awarded and how. We would also encourage folks to sign up for our Nevada Health Authority listserv to stay informed about all rural health transformation related meetings and announcements, including funding opportunities. And then we also included a link to our RHT meetings page. And as I mentioned, all of the meeting recordings and slide decks and supplementary meeting information is included on that meetings page under each of those sections. And with that, I think I will turn it over to folks for questions. Thank you so much.
Madam Chair, Stacy Weeks for the record. I just want to end with saying thank you guys for having us. I know it's been a lot. Excited to answer questions. I did want to give Melinda Southard and her team a shout out. Apparently, we are one of the few states leading on how we're implementing RHT, and we've been hearing really great feedback. So I just want to give her a shout out and let you guys know that in just a very short time that they've been able to stand this up and get it moving. So thank you guys.
Thank you all for the presentation. We really appreciate that you're here. As you know, we have been looking forward to this conversation from the beginning of the interim. And so grateful for the compilation of all of the information. I know that we have a number of questions, so we're going to go ahead and start here. Members, are there questions? Okay, Assemblymember Nadeem.
Thank you so much, Madam Chair. Thank you so much for the wonderful, comprehensive presentation. My question is regarding the Medicaid for the homeless people. As we know that right now they have many of the homeless, they have Medicaid coverage. So moving forward with the Medicaid cuts, what is the plan for the homeless people?
Madam Chair, committee members, Ann Jensen for the record. Thank you for the question. This is absolutely a population, a very vulnerable population in our state that I know many states are trying to be as creative as possible in how we support. I think the way our medically frail definition is written, the majority of people experiencing homelessness due to a health condition such as substance use disorder or a mental health condition would automatically be exempt. We recognize not everyone is engaged in the healthcare system, and so it'll be important for us to be able to get that documentation if we don't already have claims information. For people that may not be exempt, there will be, again, a range of options. We're hopeful to connect people to job supports, to volunteer opportunities or education opportunities that they may be interested in. And so we recognize it's going to be a very person-driven approach. It's going to be different for every person, but we're really committed to being as comprehensive with those options as we have a state ability to do so and help ensure that people are compliant with the new Medicaid regulations and avoid disruptions in coverage where possible. So thank you for the question, and we look forward to further collaboration with our community partners that are working with this population on a daily basis. We're grateful for them and look forward to learning how we can best support them in the months and years ahead.
Thank you so much. Thank you. Chair, can I have a follow-up question? Thank you. Thank you. So my another question is regarding the hospitals. These Medicaid cuts would have a serious impact on hospitals because when people lose coverage, they often delay treatment until their condition becomes an emergency. So that is leading to more emergency room visits, higher uncompensated costs. So how that burden, the hospitals are going to deal with that burden? Is there any plan ahead?
Madam Chair, Stacy Weeks for the record. Like I mentioned, this provider tax has been around for about 2 years. So unlike some states, this is a newer increase in funding. Not to say that it wasn't needed, but like I mentioned, there's still a couple billion that they're going to be receiving. So yes, it will be an impact, But I do think that one of the things that we're trying to work with our hospitals through our Medicaid Quality Collaborative is for them to participate more in what we call transitions of care, the value-based payment arrangements, where we're trying to help them help us avoid unnecessary ER visits. So that's something we can work on that way. But yes, there is always going to be a challenge, I think, in revenues when you lose revenue sources. Thank you.
Thank you. Next, we'll go up north to Assemblymember Goulding.
Thank you, Chair. Thank you for the presentation. I have a couple questions. One, you said, Director Weeks, you said that you were hoping to help affected Nevadans get employed quickly, those who are would be losing their coverage. Can you expand on that a little bit?
Madam Chair, Stacey Weeks for the record. Hopefully I'm not echoing. Sorry about that. Yes, one of the things that we're already talking to is DETR, our state agency, and trying to make sure that people who may be losing their coverage, that there's some sort of connection through the eligibility process, right? If they're denied eligibility, that we're letting them know that there are employment resources. One thing that I think could be helpful for next session is we start to think out budget builds and items for special consideration. One item that I think we probably want to think about is technology beyond just DETR. Is there some sort of technology and tools where we can connect people online to a lot of employment resources, other job training sites? There's a variety of technology and resources that we could probably try to, if we have the funds, to purchase that could help us do that better. But right now it's really primarily with DETR and making sure there's a handoff there to resources. But as you know, Assemblywoman Goulding, is that there's a lot of job training programs too that we need to be ensuring that we're connecting people with.
Thank you. Chair, another?
Go ahead.
When addressing the rural health transformation grants, you mentioned sustainability, and one of my concerns about that is we know our rural communities are hurting now, and I'm having a hard time imagining what those sustainability plans would look like when they're in desperate situations now. So if you make this funding contingent upon future funding, when there is nothing there right now and they're facing dire circumstances now, how do you envision a sustainability plan?
Madam Chair, Stacey Weeks for the record. Melinda, I'm going to start it and then kick it over to you. I think our point there is that we heard loud and clear from this committee and also IFC that we don't want $1 billion cliff for the state budget either. So we're trying to be sensitive to the fact that this is $1 billion over 5 years. And if there's no sustainability plans at all, everyone's going to look at this body to fund it. And we can't have that. So I'm going to turn it over to Melinda, but that is sort of our goal. It doesn't mean everyone has to be 100% sustainable, but we have to think about some sustainability strategies. It could be future grants. It could be private donations. There are a lot of people here with a lot of money that could help out. And there are other things that people are going to have to think through. Medicaid reimbursement is another one, but it cannot be a huge cost to the state. We're also thinking through if people want to bring items for next session, it could be supportive of year 2 of sustainability funds. So Melinda, did you want to talk through some of the strategies and what you're asking members to put together in a business plan?
Sure, thank you. Melinda Southard for the record. Some of the things that we've talked about is, folks may need a bolus of funding for startup costs, right? And so if it's already a project that has tried to be funded, but they just don't have the funds to start it up, the Rural Health Transformation Grant is a great funding source for that, and then they can carry it on with their additional funding. We've also, as Stacey mentioned, we've talked about Medicaid reimbursement or private donors or just other strategies. The lack of a sustainability plan does not preclude somebody from being funded through the Rural Health Transformation Grant, but it is, we would like that consideration put forward into the applications, and the stronger the sustainability plan, if the project goes on for multiple years, the better opportunity that is. Thanks.
Thank you. I agree that having a fiscal cliff is a bad scenario, so I don't criticize that objective to not be facing that. I'm just concerned that we will be, in fact, facing a fiscal cliff, and I think it's a conundrum of the funding. Certainly, it's a welcome funding source, but I think it's a big concern.
Thank you. We'll go next to Senator Titus.
Thank you, Madam Chair. I have a number of questions, if that's okay. I'll start first by thanking all of you here today, Director Weeks and your entire team. One of the things that's hard to navigate is making sure and paying attention to the human component of this. And I think all your departments have done a tremendous job making sure the human impact of these decisions that are coming out of Washington. Having said that, you're also paying attention to the potential fiscal impact to Nevada and our budget. And those are two very hard things to navigate, recognizing they sometimes have different avenues to solve. So very much appreciate your time and your considerations. Director Weeks, in the past, we have heard about a percent of eligible Nevadans that are eligible for Medicaid but don't actually access that. Do we have a number on those, and that particular number? You're throwing out numbers like perhaps 5,000 people working, et cetera. Do we have those that are currently eligible but don't apply? Do you have any of those numbers?
Madam Chair, Stacey Weeks for the record. Senator, unfortunately, the Gwen Center hasn't updated that analysis since I think it was 2021 or 17, something like that. So the numbers we used to use on that are pretty old, so we don't use those. It is a survey that I think we probably need to revamp in the state, is to really get a sense of our uninsured today. I think some of the things that we're doing to modernize eligibility and enrollment with our sister division and our exchange around Medicaid, I think will help get some of those folks enrolled and possibly reduce some of those numbers. But it is a number we don't really have really updated data on.
Well, thank you for that. And if I might continue, Madam Chair. That kind of brings me to the next question that I have. I know under decision point 1, determine short-term hardships, there's a couple issues there, and that really reaching out to folks. And I'm wondering, how exactly are you going to reach out? Do you have online assistance? We talk about, the rurals and the high unemployment counties, and how do you actually reach out to these Nevadans, or are planning on reaching out?
Madam Chair, committee members, Ann Jensen for the record. Thank you, Senator Titus, for the question. This is something that we're really wrestling with, is what are the ways that we can communicate as effectively, knowing for each of our geographic communities and general communities throughout the state, it's going to look a little bit different of actually what's effective. What we're exploring is a combination of physical outreach, mailed items, flyers and posters in grocery stores or health centers, but also our current texting and email capabilities, social media, and other mediums of getting the word out. We're also working to secure resources to find more creative ways to do kind of earned media and marketing to try to get in front of people in more creative ways that maybe we haven't done in the past. So as we have more details on that, I'm excited to share. But we also recognize that in-person connection, particularly in our rural and frontier communities, goes a long way. And we need to find those trusted community members that people already know to really communicate through. So thinking about our federally qualified health center staff, as we mentioned before, our navigators are going to be really key partners, and I'm excited to have an ability to expand that to support this Medicaid process. But I think, candidly, it will be a challenge. I think we're trying to communicate with a lot of people, and we're trying to do it in the best way possible. But we expect that there will be people that are harder to reach. And if you all have creative ideas on how we can do that better, or if you're getting feedback from your constituents throughout the process, we want to hear it, because we recognize this process will evolve, especially throughout the first year.
And last question, if I might, Madam Chair, and this is deep in the weeds. On one of your slides regarding H.R. 1, the Nevada Medicaid eligibility for immigrants, the very first paragraph mentioned certain categories that will still be covered of immigrants. And then it said, in the last line, it says, women in states that have elected the CHRPA 214 option. Did Nevada elect that option?
Madam Chair, committee members, and Jensen, for the record, those are the weeds we like to be in. So thank you for the question. Yes, Nevada does have that option, and we can get you additional detail on what that looks like. But again, all the components of how we cover those populations right now will not change. It's the additional populations that do not meet those requirements that will be impacted on October 1st.
Great, thank you. Because as a fiscal conservative, I've pushed out a long time that prenatal care really saves our state money, and I would hate to lose any of that coverage for these women and children. So thank you very much for that. Thank you, Madam Chair, for the patience with all these questions.
Thank you. Next, we'll go to Senator Lang.
Thank you, and thank you for the presentation. You always give great, complex presentations, and we really appreciate that. I have a couple questions. So on slides 26 and 27, they reflect a combined loss to the state budget of approximately 91 million to 110 million in 28 and 29 from hospital provider taxes and premium tax reductions alone. And in slide 30, it's 600 to, I think you changed it 700 million to 800 million in losses to the state's private hospital system by the end of the next biennium. So where does the health authority expect those gaps to be filled? And if they are not filled, which services or reimbursement programs or rates will be cut? And then if I could just ask you another part that you could add on to that. And are you aware of a plan that could be coming from the governor's office to deal with all of this?
Madam Chair, Stacy Weeks for the record. So that was a lot of questions. Just to be clear, the 600 to 800 million, like I mentioned, is not a budget impact. It is additional funding that will just be reduced. That it's essentially federal money that's just going to be going down for them. We don't have 600 to 800 million, but it's not going to, it doesn't affect our budget, which means there's no provider cuts. And from that specifically. Now, depends on the state revenue. There's a lot of things that happen in the forecast. None of us can see what's coming in this fall. That's a different conversation. So I don't want to sit here and say, I don't know where we're going to be, but I can tell you from these changes, we are not proposing any cuts to our budget related to HR 1, mostly because of the decisions that this body has smartly made to not use a lot of that provider tax funding to supplant general fund. So thankfully, we're not in the same position as some other states like Minnesota, as well as like Florida and Texas and others that have really relied on some of those funds for general fund dollars. Like I mentioned, and the governor's stuff, I can't speak to the budget build, so that's confidential, but you guys will find out at the end of the year. Thank you.
And if I could ask another question, Madam Chair. So we are all really concerned about the budget. I mean, we have other things that we want to include in the budget. So when we ask these questions, it's a lot to digest. Are you considering proposing Medicaid reimbursement rate cuts in the executive budget? Will your office be proposing that?
Madam Chair, Stacy Weeks for the record, not from HR 1, and I don't know again what the state's budget's going to look like and how much revenue we will have. That's reliant on casino tax, gaming tax, a lot of taxes. But when it comes to HR 1, there is no need for us to be cutting provider rates. I can tell you that.
Okay. Thank you. I may have, but that's good for now.
Thank you. Senator Danyate.
Thank you, Madam Chair. And first and foremost, before I have commentary that I think is important for the record, and then I have questions that follow subsequently. So first and foremost, I just want to thank your staff. I think God knows where we would be without Director Weeks at the helm, and so forth. I cannot underscore that. I think that in moments like this, it really does matter the leadership that we have, and I have my full confidence in your team to help us navigate this process. I also want to be cognizant of committee rules, Chair, just because I know it's important to be respectful, but I also want to make sure that the record is set straight in terms of the situation that we're going to fall into in the coming months. You know, last year, a couple of us sent a letter to you, Director, asking for projections in terms of what would it take if Congress were to make certain cuts to the budget, or of how Medicare were funded. And we, of course, it was about a year ago that we were in a similar room between the Assembly and the Senate discussing those matters. It was interesting that some of my colleagues went to the Review Journal and mentioned that President Trump wasn't planning to make those cuts and that we were crying wolf. But obviously, we've seen that that was not true. In fact, they did get enacted, and now we're in the consequence of having to figure out what we're going to do in place of that. I also want to make sure that as we go through this hearing process, you know, in my opinion, this is the most important one that we have this legislative interim. And the reason why I mention that is because we are about to step into an economic crisis with the amount of Nevadans that are going to be uninsured and kicked off of Medicaid within the coming years. And it's, I think it's implorable for all the committee members to try to solve that as much as we can, simply because of the seriousness that that's going to occur when people are put in that position. So in terms of my questioning, I know on slide 29, we talk about the utilizing the rural transformation funds. You know, I think that's just a short backstop. It doesn't really address the issues. I think it's more of a federal thing that we all have to navigate together. It's not a kick towards you guys. I think every state is having to deal with this situation. My problem with the plan that we have right now is that as much outreach as we can do to knock on the doors and educate Nevadans on how they can navigate healthcare, if they were on Medicaid and now they're going to be in a different situation, there is no proposal that I'm seeing right now to help with that coverage gap. And so my question is, and just to put this into perspective for the public, when we say 100,000 to 200,000 Nevadans are about to get kicked off, in total, that's going to be 500,000, correct? And so I just want to make sure with the current uninsured rate that we have right now.
Madam Chair, committee members, Ann Jensen for the record. On the Medicaid component, I understand your question is on the overall uninsured rate, and we can kind of speak to what that total looks like. On the Medicaid front, as Stacey noted, our estimates are continuing to evolve. We expect about 147,000 people have to meet work requirements. We do not expect that all of them will not achieve them, right? So we expect, I think Arkansas and other states have seen around 50% of people drop off, which would be closer to 70,000 people on Medicaid losing coverage. But again, we will continue to provide updates on what that looks like.
So just to be clear, I mean, our uninsured rate right now, we have about 300,000 Nevadans. So we're going to be adding about 70,000 to them. So that's about comfortably 400,000 Nevadans. So again, 500,000 Nevadans. So I think there could be a plus or minus around that differentiation. So I guess my question is, as much outreach as we can do, what are we proposing in terms of a plan for the coverage gap for the Nevadans that are going to experience, whether they are at the fall of not meeting compliance requirements with work requirements or volunteering hours, et cetera, when that moment hits, if they can't afford the plans on the health exchange because they make not enough to afford, right? But they're also are in that small window, what are we going to do to help those Nevadans? We can do as much outreach as we can, but how do we solve that coverage gap?
Madam Chair, Stacey Weeks, the record. As you guys know, we do what you guys tell us often and what you fund us. So this body passed the public option, and that's one avenue that if it does live up to its vision and its goals, it should be helpful in lowering costs. You are right that there will people that do want to remain covered will have to pay a lot of money. But the big key is looking at our private individual market through exchange. This body could fund and pass state subsidies. That's on you. I can't do that piece. So right now, the tools I have are outreach, working with vendors, technology, getting the best data match I can so it's not a burden. Doing all the things that we've been talking about, leveraging our navigators, and thank you, Senator, for that funding. All of those pieces I'm doing with what you guys give us. So if you guys want a plan like that, we're more than happy to look at that. I can't speak to what the governor's proposal will be, unfortunately.
Madam Chair, if I may follow up. Thank you. That's exactly the type of answer that I wanted. And so just to be clear, if the committee were to decide, yes, it is imperative as from all of us collectively to help solve the coverage gap. That is something that we have to address together. And we decide that the public option pass-through funds are the vehicle for that. Is that something that we have to go back to the federal government for approval, or is that something that we already have the statutory authority to do so within the state?
Madam Chair, Stacey Weeks, for the record. Yes and no. I would say it's a mixed bag. Right now, based on what we have been able to achieve in year one, we're really just only able to pay for reinsurance. So I think we'd have to rethink our proposal and what we use those funds for. Yes. We could ask for a larger target to reduce we could do that. We're looking at that now on how to generate more pass-through dollars. But as you may recall, the more we push on that reduction target, the more that our plans have to push down on other things too. We do have them pushing down on their admin costs, but they would also have to look more on their providers as well. So there's a give and take in healthcare, right? You squeeze one end of the balloon and it's somebody else that pops. So yes, those are things that we could talk through and consider, but that would have to be I would consider that a legislative request. Yeah.
Thank you. Just as a follow-up, I would welcome the ability maybe to, and I think you kind of got that based on my email correspondence, that it'd be nice to see the financials of what it would take to, say, create a program to help I'm going to call them the missing middle, right? The folks that they make too much money to qualify now for Medicaid or can't comply with it, but not enough to afford health insurance on the exchange. And so I would like to see the financials and work with your team in terms of what it would cost to work with the current ACA subsidies so that by the time they enroll when we have the navigators meet them and we get the chance to talk to them, we say, looks like you are part of that missing middle. The state passed these level of funds. Don't worry. Even though you are now enrolled in the public option, the state is still supplementing and supporting. And so I hope that we can work together to get to that point. And I just want to be clear. We can't use the rural transportation funds dollars for that option right now, correct?
Madam Chair, Stacey Weeks, for the record. I do not think so. I think that would be challenging and we'd have to get that approved. One thing I would just say, Senator, that we're waiting to see, and what we've seen from this administration at the federal level is often like if they don't like that a state, maybe state only funding a subsidy for a certain population, they will put it in guidance that if you do that, you don't get federal funding. So until we get federal guidance this summer, we're happy to help you go ahead and look at what that would cost. That's easy or easier. But once we get the guidance, I think it'd be a matter of like, is there anything that we'll be doing that might affect other programs? So I just want to throw that out there as something that we have to be mindful of.
Thank you, Madam Chair. One more. I want to come back later on. I'm just putting this as a feeler more. It's not my question, but I just want to make sure that you know that I think we have to have perhaps maybe more on a separate concurrent meeting when we talk about mental health. It'd be interesting to talk about the reductions in the behavioral health program through the mechanisms that we have. Is that going to be out of compliance with the DOJ settlement? So that's more of a commentary. The only question that I have is more on slide 18 regarding immigrant eligibility. Do we have a projection now in terms of how many individuals will be affected from this? I have always been an advocate on making sure of this. I don't need to divulge into this of the importance of level. I just need to know how many Nevadans are going to be impacted if you have some preliminary numbers on that aspect yet.
Yeah, Madam Chair, committee members, Ann Jensen, for the record. Firstly, would be happy to chat about children's behavioral health anytime. So happy to have that conversation. On the data projections on the October 1st immigration changes, we're currently projecting between 5,000 and 6,000 Nevadans may be impacted by those changes. Again, that June guidance will help us really nail down exactly what that number looks like. We plan to communicate as broadly as possible and as early as possible, so people will at least know what their options may look like, but appreciate that that is a significant number for our state.
Thank you. I do have a couple of questions, and I'd like to go back to the children's behavioral health piece, really. Can you speak to what are the impacts, given that we do have the Department of Justice settlement agreement? We are working on a robust plan. We do know that we have a lot of time and attention that's necessary to serve this population. What are really the impacts to the plan that we have?
Yeah, Madam Chair, committee members, Ann Jensen for the record. I'm excited to share that I'm not concerned about our ability to achieve compliance based on these funding changes. We've taken a very close look at all of the funding that's coming in through this account, and based on our projections for the upcoming biennium, we will be able to continue to cover everything that we plan to and have included in the implementation plan that has been reviewed and approved by the Department of Justice. We appreciate that there is less money coming in the door for that program, and we need to be as thoughtful as possible on what that looks like. But given the funding that we do have coming in, up to about $100 million in state general fund resources that we'll be able to match federally every year, or every biennium, excuse me, our projections indicate we are able to continue to cover it. We meet monthly with our Department of Justice team and our independent reviewer, and we're working very closely with them to keep them informed on what our implementation looks like. And if at any point we need to alter where those funds are coming from, that's something that we would bring to this body. We're deeply committed to this program and to transforming the way that we serve kids and families with behavioral health needs. And I'm excited for us to continue to do so. And we'll keep you posted on any long-term impacts.
Thank you. I want to go back to slide number 10, work and community engagement and what counts. Specifically, there's a lot of detail here. I'm curious to know, how are we addressing the populations that may have language barriers?
Madam Chair, committee members, Ann Jensen for the record. It's a great question. We're working, as we always do, to translate our kind of written resources and online resources into the languages that our patients speak. I think our Navigator program is going to be an exciting way to partner with organizations that have staff that can communicate in the languages that our Medicaid patients would prefer to interact with our system in. But we recognize it is really complicated information, regardless of what language we're communicating in. And so we always welcome feedback on ways to do that better, but it's a deep component of the way that we communicate in line with ADA requirements, and really trying to ensure that's done as accessibly as possible.
Thank you. And you just said it, navigators. Can you give us an update? Where are we with regard to the implementation of the navigators, so that we really are addressing these needs?
Madam Chair, Stacey Weeks, for the record, I'm going to call up Jennifer Krupp, our Administrator over Division of Consumer Health Services, so she can give us an update.
Thank you. Welcome.
Thank you so much for having me. My name is Jennifer Krupp. I'm the Administrator, as Director Weeks had just mentioned, of the Division of Consumer Health Services. Again, we are incredibly grateful for the additional funding that was allocated to the Nevada Health Authority to help support our Navigator efforts through the 36th special session. We are looking to actually publish our RFA, or our request for applications, on Friday, May 1st. So we're going through the final stages right now. We are really excited about this opportunity. We're looking to expand our Navigator or exchange enrollment facilitator population so that we are actually having enrollment assisters at points of service. And so we're really looking to base with community-based organizations and community partners to have on-the-ground support for consumers who may need assistance understanding their exchange health insurance requirements, their Medicaid requirements, helping fulfill, as Director or Administrator Jensen had mentioned, any of those exemptions they may qualify for, application assistance, and really helping Nevadans select the best plan for them or the best Medicaid option that is available for them.
Thank you. I'm going to follow up on this, and this is something that popped up in a conversation within the last week relative to community organizations who are Medicaid certified, right? So can do eligibility determinations specific for Medicaid. Have we considered that, or do we have access to that currently to better facilitate the Navigator piece that you all are initiating right now?
Yeah. Madam Chair, committee members, Ann Jensen for the record. Just want to clarify the certification you're talking about. Is that related to presumptive eligibility and helping people get access to Medicaid more quickly? Yes, always happy to speak on that. We actually just got a state plan amendment approved by CMS to expand that program. So pregnant moms can go through that process. It's a really simple form that when they're accessing care in whatever setting they're in, they can complete that and they're presumed to be eligible for Medicaid, and will go through the full and comprehensive eligibility enrollment process after that time. So our intention is to roll that out. Our tech systems and trainings for providers will be ready to go by July at the latest. So we're going to be really focused on how do we continue to expand that program and help folks get access to their Medicaid coverage earlier that they're eligible for. If particular community organizations are interested in learning more about what that looks like, we'd be happy to have that conversation. There's slightly different flavors of presumptive eligibility versus our Navigator program, and I think there's a place for anyone who wants to be part of that conversation, and we'd be happy to figure out what that looks like.
Thank you for that detail. So following up on that community organization piece, there will be volunteer hours, right, in order to help folks meet eligibility requirements. Is there a centralized data portal that organizations will be able to utilize to input those pieces so that we can streamline the determination process?
Yeah, Madam Chair, committee members, Ann Jensen for the record. I think it's a really important question, and it's kind of a two-part answer. One is, how do we connect people to volunteer resources if they're looking for something? And the second is, if they've completed volunteer hours, how do they submit that information? So the first piece, we do not have a central hub at this point. It's what Stacy mentioned. I think there's a lot of very interesting and helpful technology out there. We are trying to do is find ways to connect to local organizations, or at least include information on our outreach for where folks can go. But at this point, we don't have a single point that lists the volunteer opportunities right now. On the second piece, if you do complete volunteering with a community organization, that would need to be submitted by the member through an attestation form. Exactly what that looks like, we're waiting on that June CMS guidance, but our intention is to make that process very clear and to have all of those forms, along with all of our other outreach materials, be reviewed by our Medicaid Member Advisory Council and Beneficiary Advisory Council. So people who are actually in our program right now can advise us on whether those forms make sense or how we can improve them. So we will do everything possible to be very clear and to equip our community organizations with the information to help folks that are volunteering with them navigate that process.
Thank you. I'm almost there. Thank you. I do sincerely appreciate the detail that you've provided in this report and your presentation. There are a number of questions throughout the community, and people are very concerned and confused. And so giving us an opportunity to get this out to the public is really essential. On slide 13, you talk about high unemployment as a possibility for an exemption, right? What does that mean? What's the percentage that we're considering? Is there wiggle room to identify what high unemployment means?
Yeah. Madam Chair, committee members, Ann Jensen for the record. It's an excellent question, and one that states have been asking CMS for guidance on. This is where kind of the rule in the federal law requires a little bit more detail, and that's what comes from CMS in the form of guidance. So we expect to have more detail on what they define as a high unemployment county in that June guidance. If they decide not to define it federally, then we will have an opportunity as a state to define that, and we would bring that to a public workshop and seek input. But at this point, I do expect that they will have some sort of standard national or federal definition on that. We just don't know what it is quite yet.
Thank you. I would offer a suggestion to bring forward is that it's not just a high unemployment overall rate, but high unemployment in specific positions. So if you are trained in a specific position, is there high unemployment for that job? As a way, then we work to retrain folks through Department of Employment Training and Rehabilitation to get them employed, just as an exemption consideration. And then I do have one last question. It's really about the look back period. On slide 14, we talk about the 1 to 3 months before a person applies, 1 month prior. What does your recommendation? What happens if a person doesn't apply right away? And we're only looking back at 1 month, right? So when we look at eligibility for DETR, we're looking at the quarters, first 3 of the last 4 completed, basically. What happens if there's no compliance mechanism in that 1 month look back?
Madam Chair, committee members, Ann Jensen for the record. It's a great question, and these are the wonky ones that we're having with CMS candidly right now of here's an example of a scenario and what would that look like. If we choose the 1 month prior, my understanding, and again, I know you're hearing this a lot, we're awaiting that federal guidance in June to confirm this interpretation is correct. Our understanding is that it could be any of the 3 months prior, similar to how it's any of the 6 months prior at renewal. So for example, if they're applying and we have in April, we're looking back at January, February, or March. If we have data from DETR that would indicate they met requirements in February, for example, that would count as compliance. That's what we're anticipating. We'll see what that federal guidance looks like in June, but does that help answer your question?
Yes, it does. Thank you for that. And then I just have one final one. I want to be really clear. This really is the final question. Final. We talk about the hospital provider tax and how there's no impact to the general fund because of the way that we've structured it. But the impact then falls directly on the hospitals, right? And so I know that the state is very concerned about serving patients and the viability of the hospital network, right? Like how does the lack of or decreased provider tax then affect the sustainability of our hospitals? Rural, urban, new, right? We have a brand new children's hospital planned in the middle of Southern Nevada. All of those hospitals are building their business plans based on projections from provider tax revenue, right? Have we considered as a state, what are the implications, and are we going to be required to help shore up that hospital system if their revenues are decreased through this measure?
Madam Chair, Stacey Weeks, the record. No, we're not required to. If you guys choose to, you have to find the funding. I think that's the challenge. Remember, this program's been around for 2 years. So we go backwards about 2.5 years. So we're going backwards, $600 to $800 million. But remember, they're still going to be getting over at least $2 to $3 billion each year. Mercer initially, now again, I always preface it with federal guidance, and I hate to have to say that, but I want to be careful because it could change. But right now, when we looked at how this would impact and the way we've structured our provider tax, that the biggest impact is on our large acutes, which are our bigger for-profit. Probably not to say that they're going to be happy with me when I say this, but more likely to be able to weather it. The way we've structured our program is we've really prioritized our critical access hospitals, our sole community hospitals, so they get more of the funding under it. They have what we call kind of like a policy indicator where the funding goes. So because we structured it that way, we've kind of done our best, I think, to protect our rurals. Not to say there won't be some shifts down, but I think the biggest impact that we see coming is on our largest acute hospitals. And yes, they have been budgeting for the last 2.5, 3 years, hoping for more windfall, but I do think they're still going to make some money under this. It's just not going to be as much. And yes, the legislature can decide if they choose to supplement or replace that on their own.
Thank you. I appreciate that. Members, any last questions? Okay, thank you so much for being here. We appreciate you, and we'll officially close this agenda item. Thank you. This moves us to the next item on our agenda, item number 4, which is an update from the Department of Human Services on the changes from HR 1 to the Supplemental Nutrition Assistance Program, including an overview of eligibility changes and the department efforts to maintain a payment error rate below 6%. Welcome to both of our presenters. We're grateful to have you here. You may begin whenever you're ready.
Thank you, Madam Chair and members of the committee. My name is Laura Rich. I serve as the Director of the Department of Human Services. With me today, we have Deputy Administrator Kelly Cantrell from the Division of Social Services. We are happy here today to provide some information on the impacts of HR 1 to the SNAP program, which is Supplemental Nutrition Assistance Program. I think that the Health Authority did an amazing job setting the stage, and they gave you kind of a good, benchmark of, what those changes are to Medicaid. And so we're here just to talk about what those changes are going to be to SNAP and the Division of Social Services. I think I'm going to pass this on to Kelly, who lives and breathes this every day and can speak to this much better than I can. Go ahead.
Good morning, Madam Chair and committee members. As Director Rich said, we're going to talk today a little bit about the impacts of HR 1 on the SNAP program. And for the record, my name is Kelly Cantrell, Deputy Administrator with the Division of Social Services. So as you are well aware, HR 1 has reshaped a little bit how we administer the SNAP program. There are changes to administrative funding. It reduces the federal share of administrative funding. It is implementing a cost sharing, a share of the benefit cost on states based on the payment error rate that individual states have. It has more stringent work requirements, and it eliminates certain eligibility for immigrant families. So let's talk about the administrative cost increase first. So right now, currently, administrative costs for SNAP program are shared 50-50 between the federal government and the state of Nevada. As of October 1st of 2026, so next year, or this year, the share of costs for the administrative costs goes from a 50-50 split to a 75-25 split. And right now, it roughly takes $100 million to run the SNAP program every year. And so the impact of this is an additional $25 million per year to the general fund, to the state's budget. So what was once $50 million a year is now $75 million a year. So with bipartisan support in this last special session that we just had, we did receive an additional $19 million in funding to get us through the remainder of the state fiscal year. And starting in 27, that will be an additional $25 million ask to continue the program based on just the administrative costs, which we have no control over whatsoever. The administrative cost is very important to note here. It doesn't just affect DSS. We have 9 community partners that take applications on our behalf and do conduct eligibility interviews, and their share of costs for the administrative piece will also go from 50-50 to 75% and 25%. I'm going to pause for just one moment. Kelly Cantrell for the record. Thank you. Forgive the interruption. I think we had some technical difficulties. As I was saying, the administrative cost increase to the state does not just affect the state of Nevada and our agency, but it also affects our community partners. Overall, the collective impact to these community partners is approximately $880,000 for these partners who continue to take applications on our behalf. The payment error rate. So with the new share of cost for benefits based on payment error rate, we've never before had to do that. As of right now, 100% of the SNAP benefits are currently funded by the federal government. Effective October 1st of 2027, this could shift based on the state's error rate. The screen you see, or the slide that you're currently looking at, is a little bit outdated. We have run new projections since this slide was created, and we now know that for an error rate between 6 and 7.99%, we're at approximately 44 million, and for error rates 8% to 9.99%, it is 88 million, and the dreaded 10% of higher would be $132 million impact to the state of Nevada based on our new projections. The higher your error rate is, the higher percentage you pay, ranging from the 5% up to 15% of the benefits. So how is this error rate calculated? So SNAP cases are randomly pulled each month following mandated review requirements by the federal government. Quality control staff review these cases for all elements of eligibility to ensure that the decision that was made is accurate. And they look at things such as income, resources. They re-interview the customer. They reach out directly to the sources to verify a lot of this information. So they can reach out to the bank, to the employers to verify the information. And any case that has an allotment that differs by $58 or more is considered a payment error. And it can be $58 over or $58 under. But if the difference is $58, that is considered an error. And for each month, those errors are put together, and the cumulative amount is what makes up our error rate. The QC findings or quality control findings are then transmitted to the federal government, and they go through a type of purification process to ensure that the determinations we have made are accurate. One important thing that I like to note here is that quality control can take up to 8 hours on one case to spend verifying the information and to make sure that all elements of eligibility were accurately determined. The average caseworker processes 6 to 8 of these cases per day, with an average about just an hour per case. We don't have the luxury, unfortunately, of taking 8 hours on one case because we have customers to serve and benefits to get out, but we do make every effort to ensure that cases are going out as accurately as possible. So on this slide, you can see a little bit of the history of past error rates and our goal. And our goal, I know it says 5.99, but our goal is actually to get below 5.99. 0 would be great. I'd feel much better with 0 going into paying a share of cost for benefits. But I think a 0% is challenging, would be very challenging to achieve. We put efforts to lower our error rate into effect back in June of last year. We saw the federal changes coming. We saw the proposals, the writing on the wall. And so we made changes then to try and get ahead of this. Our error rate has never been terrible. It's always been in a reasonable amount, but we knew that it needed to come down under that 6%. And so one of the things we did is we started interviewing applicants with every application that is submitted. The federal requirement only indicates that we have to interview individuals once per year. And so we stopped doing that. Most of our people have the requirement of providing an application every 6 months. And so instead of not touching base at that 6-month mark and just taking everything based on paperwork, we now are completing interviews with those customers. One of the other things we did is we looked at, which we frequently look at, what was the common causes of our errors and what was the biggest impact to our error rate at that time. And during that time, and still today, shelter expenses accounted for a large percentage of our error rate. And so we, at that time, were taking customer attestation for their expenses. So we asked how much rent they paid. They told us. We took the statement. If we asked what their mortgage or if they pay utilities or heating and cooling costs, we took their statement and we entered it into the case and we moved on. Effective June of last year, we stopped doing that, and customers now have to verify what those shelter amounts are. We have to get utility bills, rent receipts. We talk to the landlord, mortgage statements, stuff of that nature. So those are some of the very early impacts that we made to try and reduce the error rate. In special session, along with the $19 million that we were awarded, we also were awarded funding to pick up some technology initiatives to assist us with lowering our error rate. I am happy to report that both of the initiatives that we picked up are in full swing, and we are seeing some fruits of our labors. The first one we'll talk about is a continuous evaluation of income and hours of individuals who work. So at that time, our errors based on income that exceeded the income limit accounted for 1.46%. And so with this new platform, once a month, we receive a report, and it lets us know that if any of the individuals that we have that are showing income, if that income has gone over the income limit, it lets us know in a report. If we have individuals who aren't working, who haven't reported income, and they now are working over that income limit, that's on a report. And so those reports we've received twice now. We have received over 3,000 individuals and we have closed over or readjusted over 3,000 cases to account for their actual income and hours worked. And so moving forward, the 1.46%, we definitely anticipate to drop drastically based on this technology, because it's allowing us to identify anyone whose income goes too high for the program, or if it's gone up high enough to cause an error. And it's easy for individuals to get a raise and not think the first thing they need to do is call SNAP and report to the program that their income has increased. So this is very helpful for us, and we anticipate that part of our error rate to go down. The second solution we have is a data analytics platform. And what it does is it incorporates all of the case information for our entire SNAP caseload, and it looks for anomalies in shelter expenses, in income. It can tell us if multiple cases have the same phone number. Yesterday, we identified a case where the same phone number was used on 45 cases. The good news was, out of all of the 45, only 2 of those cases were active because our staff had identified that something was wrong with the cases, and they recognized that there was an identity issue on those cases. And so through this initiative, we have saved already over $25,000 that would have been misspent SNAP dollars. And whether it's underreported income, whether, let's say one of my employees accidentally, instead of putting $1,000 a month in rent, they put $10,000 a month in rent, which could drastically change the SNAP allotment. Those things are identified, and our team of quality assurance goes in and they either update the case or terminate it if termination is warranted. And in some situations, we do reach out to the customer because we have to verify what information we're looking at. We have high hopes for these initiatives. We have high hopes that in the coming months that those will affect our error rate. One thing that I do want to note is that quality control works retroactively. And so they just finished reviews for December. And so it'll take a few months before they catch up to these initiatives. But by the end of this review cycle, we're hoping that we see great impacts. One of the things I do want to put out, I'm going to shout out to the team and to everyone who does this eligibility work, is on the screen. It shows a 6.2 current error rate. Our error rate was just reported 2 days ago. And for the first 3 months of this review cycle, we are at 5.79. And that's very close.
I just want to point out, sorry, I didn't mean to interrupt, but I just want to just point out that we're having more technical difficulties. The screen is not showing what our laptop is showing. So I know you just said on the screen, it's not on the screen.
Kelly Cantrell for the record. So if you had a screen and if you could see it, you would see that it is showing our error rate at 6.2%. And indeed it is 5.79. And while this is very close to the 6%, I do want to point out that at no time during last year was our error rate showing a 5.79. And being this early in the reporting cycle, having an error rate that low reflects good for the future. I'm going to pause again.
There we go. Thank you.
Okay. Kelly Cantrell for the record. So I'm going to leave this here. I'm just going to, current error rate is 5.79, and we're going to go ahead and go to the next screen, the next slide, and talk a little bit about the SNAP work requirements. I know we heard a lot about the Medicaid work requirements this morning. They are quite similar. As we move through, you will be able to notice some of the similarities. Nevada has been under a waiver from ABOD work requirements for the past 15 years. And on January 31st of this year, the ABOD waiver that we had expired. And with the new rule, waivers are not approved anymore unless your error rate is 10% or higher. And as we know, the state of Nevada currently is sitting at about a 5.3% error unemployment rate. And so we do not meet that 10%. However, we do still request the waiver from ABOD work requirements. And because Mineral County does have an unemployment rate at 10% or higher, that county is exempt from ABOD work requirements. So despite the fact that we know the majority of our state isn't at 10%, we will continue to request this waiver every year to see if anything changes. Individuals for ABOD work requirements, ABOD stands for able-bodied adults without dependents. For individuals aged 18 to 64 who receive SNAP can only receive SNAP benefits for 3 months out of every 36 months, unless they're either A, exempt from the program or the requirements, or B, they're meeting the requirements. And so who is an ABOD? Ages 18 to 64. That's a little bit of a change, and we'll talk about that as we move along here. Anyone who is physically or mentally able to work, anyone not living in a SNAP household with a child under age 14, and anyone who is not pregnant. So let's talk about the age limit change. So prior to this legislation, the age requirement for ABOD was 18 to 54. With the change, that requirement went from 18 to 54 to 18 to 64. And that 54 to 64 age increased the people who must cooperate with this by over 20,000. So this is hitting over 20,000 individuals between the ages actually of 60 and 64 who will now either need to be exempt or cooperate with these work requirements. Previously, a parent with a child under 18 was also exempt from these requirements, but the age has changed to under 14. So now if you're a parent with a child in the home, to exempt you from this program, the child would have to be age 0 to 13 years old. And lastly, certain exemptions that were once on the table and that we could use have been suspended. They haven't been done away with, but they are suspended through October 1st of 2030. And those exceptions were veterans, youth who aged out of foster care, and homeless individuals. And so those exemptions won't be back till October of 2030. So how do we meet work requirements? So the first and easiest thing that is on the table here in front of you is work at least 20 hours per week, or work enough to account for 20 hours times the federal minimum wage. So let's say in Nevada, you are paid more than the federal minimum wage. You can take what they earn, divide it by the federal minimum wage, and if it equates to 20 hours, that's allowable. And I know that's a little bit in the weeds, but it doesn't have to just be 20 hours. It depends on the earnings that an individual would make. On the job training, community service, vocational schools or training, volunteer work, work programs such as cooperating with our TANF program work requirements or our SNAP program work requirements. Many of those can also help someone meet the requirements of the ABOD program. So lastly, I want to talk about who it doesn't apply to. It doesn't apply to children. Work requirements do not apply to children. So 0 to 17 do not have to meet ABOD work requirements. Seniors age 65 and older, it does not apply to them. Pregnant individuals, members of Indian tribes, it doesn't apply to. SNAP households with children 13 and under, and people with disabilities. So if there's a bright spot, that's what it is in that regard. So the next thing we want to talk a little bit about are the non-citizen categories who were previously eligible, who are no longer eligible with this implementation of HR 1. So some of the common ones are the refugees, parolees, asylees, victims of trafficking, and a few other little lawfully residing non-citizens are no longer eligible based on their status. Who does remain eligible are your U.S. nationals, your legal permanent residents who have been here 5 years or more, Cuban Haitian entrants, and those who entered as part of COFA, which is the international treaty that we have with Pacific Island nations. So Marshall Islands, Micronesia, and Palau. So those are the ones who are across the board eligible and are not affected. So this particular change we did back in August of last year, and it was just over 2,000 individuals that lost eligibility due to their status change. Either I went really fast or we're wrapping up quick. I'm not sure which, but let's talk about overall changes and what does this impact look like? What does this feel like? So the 75% of the administrative cost is big. We talked about the financial impact that will have on the state as a whole, and with community partners who currently do assist us with the SNAP program and taking applications on our behalf. Initially, the changes in this bill, we realized affected over 133,000 individuals, whether that was through work requirements or the non-citizen changes. And as of the 1st of May, we anticipate seeing a reduction in 27,700 individuals who will lose eligibility due to these work requirements. Initially, that date was February 1st. Then they pivoted a little bit and let us know that we could continue to live out our waiver, and we will now see this loss as of May 1st. Now, if this loss holds true, if truly 27,000 plus individuals lose eligibility on May 1st, that is roughly a 6% of the total SNAP number of recipients that we have. And each month in the last 12 months, we issued approximately $89 million a month in SNAP benefits. And if you reduce by 6%, it is a $5.3 million reduction in Nevada's economy, to be fair. So it's not just the people who will lose the benefits, but it's also the food chain, the entire food chain. So it's easy to think right off the bat, if SNAP benefits go down, who's the first person impacted? Retailers, right? That's an easy one. You can get there without thinking about it. But what we don't think about sometimes are the other people who are in the food industry, the farmers, the ranchers, the truckers who bring the food in and out of, or travel it, right? Trains. There's a whole different many ways that this happens. So anyone that works in the food supply chain is affected by the reduction of $5.3 million. And that's Nevada. We're a small state. We work closely with our partners in California, and they're 10 times our size. And so when you think nationwide, this is a big impact. The USDA has estimated that for every $1 in SNAP benefits that are spent, $1.54 comes back to the local economy. And so when it is a $5.3 million actual decrease in funds, if you take that into account, it's more of an $8 million impact in reduction that you will see based on these changes and the amount of people who could lose benefits. We will know more about how many actually receive benefits as we move into May, but the anticipation is 27,000, just over 27,000. So with that, I will go ahead and stop here and make ourselves available for any questions that you may have.
Thank you for the presentation. As we begin with questions, I want to get loud and clear the numbers. 27,000 individual people are expected to be affected May 1. Is that correct?
Kelly Cantrell for the record. Yes, ma'am, that is correct. And that equates to just over 23,000 cases. So yes.
And the financial impacts to that. And thank you so much for calling that out, that there's an entire food supply chain and demand, not just affecting the individual benefit recipient, totaling $5.3 million in reduced food supply chain dollars, which then equates to approximately an $8 million impact when you look at the economic impacts of those dollars.
Kelly Cantrell for the record. Yes, ma'am.
Thank you for that clarity. Members' questions? Assemblymember Hibbets.
Thank you, Chair, and thank you for your presentation. I have a question on slide 6 when we're talking about error rates. I'm a bit concerned that lodging dollars or shelter dollars, as you put it, there was no verification until last June. What else is not being verified?
Kelly Cantrell for the record. At this time, that is the only thing that was the only thing that wasn't being verified at the time. And that was a concentrated effort to reduce our timeliness impact, how quickly we were getting cases done, And we have always maintained a relatively low error rate, certainly much lower than the majority of the states. I will say right now, the average error rate in the nation is 10%. And so even last year closing out at the 6.49%, which I think is unpurified by the feds at this point, we took that on as a concentrated, we knew that there would be some impact to that. And we can't do that anymore. We have to get it down under 6%.
Thank you. A quick follow-up, Chair. I believe you had said in one example that there was 44 different cases using the same phone number. I believe that was the number, and 42 of those were already determined to be fraudulent. Have any of these been referred for prosecution?
Kelly Cantrell for the record. Thank you for the question. So there were 45 of them. 43 had already been closed and had been identified, and currently our investigations and recovery team is working with the district attorney and other law enforcement agencies. Yes.
Thank you, and thank you for correcting my numbers. Thank you.
Next, we'll go to Senator Titus.
Thank you, Madam Chair. And again, thank you for recognizing fiscal impacts, but most importantly, the human impact of these decisions that we're being handed down. I want to address page 9, and you brought up, and I appreciate you addressing this, the 5.3 million reduction in Nevada economy. Is the state doing anything to reach out to the small businesses, the retailers, and potential impact of where folks visit, the corner mom and pop store where they're, they rely sometimes on these SNAP beneficiaries to come into their stores. I know that other states have. We're not the only state being impacted, and I know Florida has reached out a little bit. And are we doing anything to address this?
Thank you for the question, Senator Titus. Kelly Cantrell for the record. We have worked very closely with not only retailers, but our community partners in every aspect of this. We have created toolkits that we sent out via listserv, not only to help build a robust volunteer site for individuals who want to continue receiving eligibility, but to also inform and notify individuals that this is coming. I have spoke with the Nevada's Retailers Association, as well as the association who represents the rural areas in our state. And so they are informed. They know this is coming. We work closely with the food banks. They know that there is going to be an impact to the food banks and to people who need assistance. So I'm not sure if there's anyone that we haven't spoken to in this regard, but it is definitely a community working together to try and reduce the number of people who lose eligibility and to try and point people in the correct pathways so that they can continue to receive some type of assistance. So yes, ma'am.
Just a brief follow-up, mostly a comment. I think I appreciate you reaching out. I think the larger retailers can absorb this, the Walmarts, the Rayleighs, the Krugers, whatever, they can absorb some of this. But those small folks that like in my little rural communities, they might have a tougher time. I'm wondering if there's been any, and I know you didn't mention it, but some of the foods, if you look at Florida's list, and we've been addressing some of this, and we've been almost mandated that we have to go to quote unquote healthier foods, whatever that definition may be. Have we done it? Is there any assistance to let these retailers know that maybe they should stock granola bars instead of some of these, refined sugars? Just again, not that I just think we need to offer them some assistance on some better ideas that they might have, so they know what's happening out here when we make these decisions, that those donuts may not go bottom, and maybe offer better choices. Do we do anything like that at all?
Kelly Cantrell for the record. At this time, the definition of food is set by the USDA, and it is very broad, and it just indicates that if it's a food product, not alcohol, tobacco, or anything of those natures, that it is a covered item. And a retailer also has to have specific items that it carries, and so many of a specific item. So it has to have X number of dairy, X number of carbohydrates, proteins, stuff like that. But at this time, we are not doing anything in that realm to talk to grocery stores. SNAP Education is a program that has sunset, and as of September 30th of this year will no longer be a program that's in existence due to the changes in HR 1. And so those individuals were responsible, and currently are today, are responsible for nutrition education and helping individuals make the right choices or make their choices stretch financially, if you will. When that program sunsets, I think that we will lose some of that conversation, although we do try to have those conversations as much as possible.
Well, hopefully we can do as much as possible and not just ignore it. And I appreciate you being here. And thank you, Madam Chair, for the questions.
Thank you. Before we go to the next question, I just want to clarify there's a little bit of confusion up here. Are we talking about a $5.3 million reduction monthly or annually?
Kelly Cantrell, for the record, monthly.
Thank you. I just want to make sure that that's extremely clear. We're talking about a $5.3 million reduction monthly to our residents, which will have a significant impact on just our local grocery store. And with that, we'll go up to Assemblymember Goulding for the next question.
Thank you, Chair. Thank you for the presentation. I had the opportunity recently to talk to some of your frontline workers who are working with DSS clients who are losing their eligibility, and one of the things that they expressed was that in the past they were able to provide information to folks who were losing their benefits with information that gave them guidance on where they could find other resources. And what they told me last month is that they were no longer able to provide any information that wasn't printed material from the department. Can you expand on that and explain why those frontline workers aren't able to provide information about resources to help folks?
Kelly Cantrell, for the record, thank you very much for the question. At no time have we ever instructed our frontline staff that they cannot provide resources to our customers. One of our greatest assets is our ability to know what resources are out there and be able to relay that information to our customers. Frequently, we will use Nevada 211 to get information from them because it is the most updated resource information that we have access to. But just as during the government shutdown, when we provided information regarding where food pickups were and where items were made available, we do encourage staff, and maybe we need to do it again, to provide that information to our customers. But we definitely have not formally or informally, as I'm aware of at this time, indicated that our staff cannot have these conversations with our customers, or that they can only discuss what is formally printed. That is the first time I'm hearing that. So I think that needs to be, I'll take that back, and we will make some changes and have some conversations.
Thank you. I think that there are some folks that are very passionate about helping folks in Nevada, and they'll be very happy to hear that they are allowed to provide that information, because I know that if that was a misunderstanding, they definitely wanted to be able to provide that information. So thank you for that clarification. I know that those employees will be happy to hear that. The second question that I have is, so I appreciate the fact that there's a federally mandated threshold level on the air rates. But one of the things that I think is important to keep in context is the cost of driving those air rates down. And I'm wondering if you have quantified how much it's costing to reduce that error rate, and if you keep that into consideration.
Kelly Cantrell, for the record. So a lot of the things that we're doing, we are doing with the staff we currently have. So as far as staffing, there hasn't been any increase or any cost. What there is increased administrative time spent having these conversations and talking to individuals about these things. Now, the money that we were awarded in special session was just about $3 million for the remainder of this biennium to stand up the 2 technology initiatives that we are currently doing right now. We are considering future initiatives. We are looking at future initiatives. But I will say that the cost of these is far less than the amount we would pay if we did not meet the 6% or, heaven forbid, 9%, 10% error rate. Those costs are staggering. And so while there is some cost to this, it is definitely far less than the anticipated payment we would have to pay for the benefits if it got to that point.
And Laura Rich, for the record, I just wanted to add too that the technology that we've put in place creates efficiencies as well. So right now we have humans that are doing the very manual work of verifying all of this. This is very manually intensive. It takes, as Kelly mentioned, it takes a lot of time. And so the technology that we're putting into place, yes, it costs money, but in the end, it actually reduces our costs. It saves money just because of the efficiencies that it creates. You can do a lot more with that technology to reduce that error rate. And again, it saves us not just in the costs that come with a higher error rate, but it also just increases efficiencies through our own human resources, and we're able to use those staff for outreach, for some of those high touch cases, things like that. So I think that there's trade-offs there as well.
Thank you. There was a number that you shared earlier that surprised me. So yes, certainly technology in the long run is less expensive. When you just said it isn't costing anymore, but then you went on to say that it is very costly in time. So it is very costly to reduce the error rates. So, and I appreciate that moving to a more technology-oriented solution will be in the long term less expensive. You said you found $27,000 that had been awarded fraudulently. $27,000 seems like a pretty small number when compared to the labor required to uncover that $27,000. And that was a surprising number to me, and I think that that's important to keep in context. Did I misunderstand the $27,000?
Kelly Cantrell, for the record. I think so. So that money, it was $24,000. That has come by way of a technology initiative that identified $24,000 worth of increased income, if you will. And so one of the errors that we have that caused over a 1% error rate was when individuals would have a job or not have a job at all, and they would either get a raise or obtain employment that put them over the income limit for the program. That was accounting for, like I said, about a 1.5% of our error rate. This initiative identified those cases that either had an increase in income or had new income that would have changed the SNAP benefit by $58 or more. And so we were able to save $27,000 so far by identifying increases in income that we otherwise may not have known, especially not as timely had it not been reported, had we not had this initiative. I hope that made sense.
Thank you. Was that $27,000 a year or monthly?
So Kelly Cantrell, for the record, the $24,000 right now is cumulative for the first report that we received from the technology initiative. So that report will be received once per month, and we don't know yet if that amount will hold true, or if as we move forward, we will see a reduction in the overall errors that we find, because once we find them and address them, that number should go down.
Thank you.
Thank you. Next, we'll move to Senator Danyate.
Thank you, Madam Chair, and thank you, Director and Ms. Control for being here. I just want to make sure, most of my questions are related to federal waivers in terms of some of the mechanisms of, okay, so this happened, what can we do next? But I just want to be clear. So in terms, because part of this is in my math of what's coming after this. To be clear, I guess my first question is, in total, it's my understanding through public reporting that we estimated that the population that's going to be affected from these new requirements and so forth, we estimated that to be 122,000. Is that still correct? Within the next, let's say, I know that there's federal litigation going back and forth, but anticipated it's around 120,000. Is that still accurate?
Yes, we started with Kelly Cantrell for the record. We started with an anticipated number of being about 133,000, but once we purified it, it did go down a little bit to 122,000. That is the number of overall people who were affected by all of the changes in the HR1 legislation.
Great, thank you. And so just for the public to understand this, so there are 122,000 or so Nevadans that we anticipate that be affected right now. That doesn't exclude the people that will be denied when they come into our offices because they don't qualify just the same way amount that we would have in general, right? When folks come in front of our offices. So the reason why I wanted to mention this was, and I think this is, I'm just going to point back to the historical record. There was some discussion earlier during this interim when we were talking about some of the waivers that the office was taking on. I had obviously shared my discontent with the SNAP waiver that's being implemented right now for the coverage of soda and snacks and so forth. And I want to be clear that the reason why I was so vehemently against it is not on the policy front, but it's because this to me is more of a priority that we have to be looking at. It's about misplaced priorities. And so the amount of effort that your staff is going to undertake for the error rate and developing contingency plans if we fall over that to me is more of a pressing priority than anything else. And so I think from my perspective, I want to hear from you in terms of the feedback. So this is part of I'm trying to understand this as well. When it comes to waivers submitted through the USDA, it's my understanding that they're not as flexible as Medicaid often is or CMS is in terms of acceptance. And so do we have the ability to say, can we submit a federal waiver to the USDA that says if the unemployment is high within a certain county, say Nye County, Mineral County, that we can suspend the work requirements because it's leading to an impediment? Is that something that we can do? And if so, are we working on submitting something of that essence?
Kelly Cantrell for the record. Thank you, Senator, for the question. So the way it is current, we could request a waiver for anything we wanted to be honest with you. Whether or not it's approved is a different conversation. And we have submitted, I want to say at least 3 to 5 regarding some of the changes that are in this bill. As of right now, it's very clear that we do submit a waiver every year for ABOD work requirements and to try and see if we qualify for an exemption as a state or by county. Right now, the exemption, give me a minute. So right now, you have to have an unemployment rate at 10% to qualify for the waivers. And in Nevada right now, the only county that meets that number is Mineral County. So when we did our ABOD, when we submitted it this year and said, looking for exemption, once again, the only county that was granted the exemption from the ABOD work requirements was Mineral County due to the unemployment rate in that county meeting the 10%. The rest of the state was not approved, and we have implemented the ABOD work requirements in every other county throughout the state.
Great, Madam Chair, if I could follow up. So the reason why I was asking that, so again, submitting a waiver is different from the acceptance of the waiver from the administration. And so in my similar questions that I was asking to Medicaid and the health authority earlier, right? If the legislature were to decide that we want to cover, as I mentioned, the missing middle, right? The folks that were impacted from the implementation of HR1 that now are finding themselves in the middle, right? Where they can't afford their groceries because now they're kicked off of SNAP, or they can't afford their healthcare through the exchange because they made too much but not enough, right? If the state were to implement a state-funded parallel program to help supplement those individuals, I just want to understand that my math is correct. On average, we spend about, 2,700 per person on SNAP. Is that an accurate assessment?
Kelly Cantrell, for the record, it's the average person is about $193 per person on SNAP per month.
Okay, so it's about, we would say 2,000 something. I mean, if I'm trying to get an annual assessment in terms of how much per person. So
Kelly Cantrell, for the record, yes, it would be just right around 2,000, a little over.
So if I'm doing my math correctly, just obviously mentally, I mean, we're talking if the state were to implement a parallel program to cover the missing middle that were affected by, again, the 122,000 that I started off with my questioning, we're looking at a program that would be around 200, 250, 270 million in state general fund dollars just to go back to what we had before in each year, correct?
Kelly Cantrell, for the record, I'm trying to math that out in my head as well. So 5 million per month is what we anticipate reducing by 5.3 million. So times 12 would be over $60 million per year. Little more than that based on fuzzy math, but yes.
Great. So, and the reason why thank you. So in the biennium, it would be anywhere from 122 plus, right? I think that's kind of the rationality of why I'm asking these questions is because I think it is imperative for us to discuss what it would take to get back to the normal, what we had before. But I mean, for the state to be able to absorb such a cost within the next 10 years, I think is becoming astronomical. And that's on top of what we have to deal with Medicaid. And so I think it's imperative for Nevadans to understand the severity of what we're facing and how this is not just reverberating on the individual purchasing dollars of a person, but also to the economy of scale that we were talking about with small wholesalers, grocery stores in the rural areas and so forth. And so that's why I wanted to ask for verbatim in terms of what it would cost for us to get to that point, because I think other states are finding themselves in that situation. And the answer is there probably isn't an answer. So thank you, Sola.
Thank you. I have one question, believe it or not, just one. I want to go back to the work requirements, 62 to 64, right? So now we are changing the age requirements. We've gone from 54 to 64. But specifically, doesn't Social Security kick in at age 62? So like we're asking people who are now required and receiving Social Security to go back to work. Is that in essence what we're doing?
Kelly Cantrell, for the record, if they are not disabled or meeting any of the other exemptions, yes, ma'am.
Okay, it just feels like we're a little bit federally in conflict with, hey, you can retire, but psych, you can't. Now you have to go to work. So I want to make sure that we're really clear. We are now moving this benefit after Social Security qualifications. Okay. Okay, members, any other questions? No? Okay, thank you. Thank
Madam
you so
Chair,
much.
can I just add just
Please.
a few closing comments?
Yeah.
I just wanted to add, Laura Rich for the record, our SNAP and Medicaid have a lot of overlap. I think it's about 90% of SNAP recipients also have Medicaid. And so I just wanted to make this body aware that that DHS is working very, very closely with the health authority as well, in our outreach efforts, in, a lot of the work that we're doing with the work requirements, with our technology efforts. Director Weeks and I are working as closely as we can to ensure that this population, because it's a collective population between DHS and the health authority, and to make sure that we are protecting as many Nevadans as we can, and getting the word out and finding ways to communicate and do outreach and educate our people, and ensure that we can catch as many as we can. We know we're not going to catch everybody, but I think between the two departments, we're going to do a great job of doing the best we can.
Thank you for those statements. We sincerely appreciate that you're here and that you're leading your division in such a way that cares for Nevadans. So I thank you for that. And thank you very much for being here today and presenting this information for us. We will close this agenda item. We are now at 11:46. So given the fact that we will take a break for lunch, what I would like for us to do is take the next presentation. So we'll open up agenda item number 5 and take the first presentation, which is hospitals. So if you will please come forward, we will discuss the impacts of hospitals and health centers by HR1. So we'll do this first presentation and then take questions, and then we will break for lunch for a short period of time and then come back and do the last 2 presentations. Thank you for being here, gentlemen. We see Mr. Osborne up north. You may begin whenever you're ready.
Thank you, Madam Chair and members of the committee. Blaine Osborne, for the record. I am the president of Nevada Rural Hospital Partners, and I also have the honor of serving as a member of this body, representing District 39. If it's okay with you, Madam Chair, I'm going to go first as I have a hard stop, and I appreciate your flexibility with my schedule, and then I'll turn it over to Mr. Kelly and Mr. Von Howling for the rest of the presentation.
Thank you, Assembly Member. Go right ahead.
Thank you. Really appreciate the opportunity to be here today. As you all know, Nevada Rural Hospital Partners is the association of the 13 critical access hospitals in the state. That is every rural hospital with the exception of Elko, which is a little bit larger. I also wanted to mention we're very grateful for our partners, the Nevada Health Authority, Nevada Hospital Association, Department of Human Services, the Office of Rural Health, the Primary Care Association, and the Governor's Office, who we've worked very closely with on the implementation of HR1 and, of course, the Rural Health Transformation Program. Nevada Health Authority did a great job covering the eligibility and work requirements, which our critical access hospitals will see some impacts from. Our member hospitals see anywhere from about 10% of their patient population to as high as nearly 40% in some of our communities on Medicaid. 6 of our critical access hospitals participate in the private hospital provider fee program at a net benefit of roughly $22 million per year. So that is some of that loss that Director Weeks spoke about earlier. While we wait on guidance on implementation of work requirements from CMS, our member hospitals are busy educating themselves, their frontline staff, and patients on eligibility requirements. They're busy working to try to increase community health workers and patient navigators to assist patients, and are trying to work with those affected to offer opportunities for work and volunteer hours to try to help comply with those work requirements. I wanted to talk briefly about the Rural Health Transformation Program. As has been alluded to in several of the questions and comments this morning, the Rural Health Transformation Program will not be any kind of a one-to-one offset for projected losses to Medicaid for our member hospitals. But what it is doing is allowing our member hospitals to get ahead of some very costly expenses, to do some modernization of property, plant, and equipment, and hopefully be in a much better position to be able to withstand any losses projected from HR1. I wanted to say, too, the legislature has done really well in the last couple of legislative sessions supporting our critical access hospitals with the passage of cost-based outpatient reimbursement and the rural emergency hospital designation, as well as other supports. So thank you for that. Because of those bills, our member critical access hospitals are in a much more stable financial position currently, and the Rural Health Transformation Program is hopefully only going to help that. As you know, the primary focus of the Rural Health Transformation Program is to benefit rural Nevada's residents, patients, hospitals, clinics, and providers. I want to thank Nevada Health Authority for all of the work they've done in establishing the applications and the processes to support this effort. One great example of that is in the Nevada Flex Fund, which is the grant application that is supporting infrastructure costs. The Nevada Health Authority is requiring that any of those applications demonstrate a commitment from rural hospitals, rural clinics, rural providers through letters of support, MOUs, whatever that agreement is, to show that we're not just distributing RHTP funds to outside vendors or entities, but that those dollars are actually going to partner and assist rural communities. We have member hospitals busy submitting their applications right now. The Flex Fund, as was mentioned earlier, is due later this week, I think 2 days from now. And those other grant opportunities are all in various states of opening and submission. But our member hospitals have worked together to put forward applications that include equipment upgrades for their aging buildings, AI opportunities and innovation, workforce recruitment, retention, training, minor alterations and renovations, transportation, mobile simulators, mobile imaging, more specifically beds, bassinets, stethoscopes, imaging equipment, boilers, chillers, generators, new transit vans, ambulances, and housing supports for providers as well. And so what we're really trying to do as an association and our member hospitals is to try to transform. We're taking data-driven approaches to try to improve patient outcomes, expand services and service areas, and improve payment models through Medicaid to ensure that our Nevada rural hospitals are never put at risk of closure. Collaboration, shared services, leveraging of funds, regionalization, where appropriate, are all goals that our member hospitals are currently trying to implement. For example, if 2 or 3 of our hospitals that are close to one another can share a pulmonologist, alone they don't have the volumes to be able to do that, but sharing, where you can have a provider in one community for 2 days, another community for another 2 days, and a third community for a 5th day, those are the types of innovative approaches that our member hospitals are taking with Rural Health Transformation Program. So with that, I would open it up to any questions before I have to leave, and then I would turn it over to Mr. Kelly and Mr. Von Helling.
Good morning. My name is Patrick Kelly. I'm the CEO of the Nevada Hospital Association, and we appreciate the opportunity to present here today. A lot of the information we were going to cover has been covered by other presentations, so we're going to move a little bit quickly, but we do want to show you some of the practical ways that these changes are going to impact hospitals. So just starting off with the basic slide to let you know that we're probably looking at a little over 20% of the state's population that will be impacted by the changes in H.R. 1. And I think to have any discussion about the impact, you have to understand a little bit about hospital Medicaid reimbursement. And there's basically 2 categories. One is base rates and the other is supplemental payments. So base rate is what we get paid for delivering a particular service. For example, with newborns, we get paid $327 per day for the newborn, and that's the base rate for that service. Now, supplemental payments, and that's what we're talking about primarily today, is a fixed amount that's paid over a period of time when you've provided care to a group of Medicaid folks. So one of the things I want to make sure you understand is that on these supplemental payments, hospitals only get them if they're providing care to patients. And some hospitals get more because they treat more Medicaid patients, and some hospitals get less. So it all has to do with serving the Medicaid beneficiaries. So to look at the base rates, over the last 23 years, we've only had a 5% increase in base rates for hospitals. And that has not even come close to keeping up with the inflationary costs that we've experienced. I'll give you an example. And the American Hospital Association just put out this chart that in 2025, our drug costs increased 13.6%, supplies 9.9%, and workforce went up 5.6% for a total expense increase of 7.5%. That's only 1 year, and the med-surg rates, base rates have only gone up 5% in 23 years. So we've not been keeping up with that. And that's why these supplemental payment programs are so incredibly important. And I have to give a lot of credit to Stacy Weeks and her team at Medicaid, because they work diligently to help us put together the private hospital Medicaid provider fee program that 43 hospitals participate in. And that's the one that's getting hit hard. So, kudos to them for doing this. But, we were doing well. We've had hiccups along the way in getting this thing started. As she said, it's about 2 to 2.5 years that we've gone, but it seems like every quarter something comes up, and it's not Nevada Medicaid's fault. It's been mainly at the federal level. For example, when we had the shutdown, federal shutdown, we couldn't get our preprints approved. You can't get the preprints approved. You can't get money distributed. So it seems like there's always been something that delays this program and getting the money. Now, we've gotten the money. It's just not coming in on a regular basis like we would like. But HR1 is going to be absolutely a game changer, because this was coming in. These supplemental payments were really making a difference. And now we're going to have a little bit of trouble with significant reductions in payments. So if you look at this chart, I've got state fiscal year 27 be 15 million cut, 28, 300 million, 507 million. You heard earlier higher numbers. Here's the frustrating part about all this is that these numbers change all the time. I used to, when I first gave this after HR1 passed, talk about $200 to $300 million in cuts. And it just seems like it's going up all the time. And as Director Weeks said, the issue is we're waiting for guidance from CMS to tell us what the rules are and how it's going to be calculated. Until that's done, we're really not going to know where we're going to fall on this. But I'll just simply put this: it's going to be a whole lot of money, and it's going to have a big impact. So, as they say in the commercial, but that's not all, there's more. And that's the situation here, because not only are we going to take that cut, but we're going to also be taking additional changes from other aspects of the bill. And that's what I want to talk to you about. So we talked about Medicaid eligibility. We've got the work requirements going in, and we're going to have redeterminations more frequently. So we're probably going to have people falling off of Medicaid on a routine basis. And so that's going to be a problem. And of course, when they're off Medicaid and they come to the hospital, they're going to be uninsured. And so we're going to be providing care to people and not receiving any reimbursement for that. Retro Medicaid eligibility, a little bit was talked about that, but right now, if a person comes to the hospital and they don't have any insurance, we try to get them signed up for Medicaid, if they qualify. So right now we have 90 days to do that. Under this new bill, we're going to have for one group 60 days and for another group 30 days. So if you were part of the expansion enrollees, you only get 30 days. And if you were would have fallen in under traditional Medicaid enrollees, you get 60. But by the time you work with this person to get all the documents and all the information you need, 30 days is not a lot of time. So what's going to happen is we're going to have even more uninsured people that are going to come in, because we're not going to be able to get the paperwork and everything done and submitted in time. So that's a concern. I've put on a slide about non-citizen Medicaid eligibility. I know Director Jensen did a great job in explaining that, so I'm not going to go into detail. This isn't a huge financial for us. We will lose money because these people will be uninsured, but boy, for the people who used to fit in these categories, it's going to be a really big deal. So we need to worry about them. And then the premium tax credits. I just wanted to mention this. This is not part of HR1, but it all happened near the same time. When we did the Affordable Care Act, we put in a program where low-income people would get premium tax credits to help them pay for their insurance. And then during the pandemic, the American Rescue Plan expanded the number of people who could receive that benefit as well. Now, the problem in the American Rescue Plan is that it had a time period where it was going to end if it wasn't renewed. And that ending period was the end of last year. And a lot of people thought HR1 would renew that and allow that group to continue to receive the subsidies. that didn't happen. So as a result, we've got a lot of people who are not going to get that benefit. And we've been anxiously waiting to see how many people are not going to have insurance as a result of that. That's not answered yet. To give you an idea, in 2026, we had about 104,000 Nevadans enrolled in coverage through the marketplace. 95,000 of those individuals received some kind of enhanced subsidy, and that number is going to drop. So KEKF, the Kaiser Family Foundation, estimates that there'll probably be about 24,000 Nevadans not having insurance by 2034. So what does this mean from a hospital's perspective? People are going to make the decision as to whether they're going to go without insurance or not. And I think that there will be people who do that, or they're going to go out into the market and buy cheaper insurance with super high deductibles. Well, sometimes these deductibles discourage people from going and getting routine health care because it comes out of their pocket. And as they delay receiving health care, a lot of times they just get sicker. And so when they come to us, we have a huge number of people who come with these high deductibles who just can't, there's no possibility they can pay us. So they basically become uninsured for their deductible part of their insurance. And so, you have a $6,000 deductible and you've got a bunch of people coming in who can't pay the $6,000. It obviously impacts the financials of the hospital. So the overall impact is that we're going to see a lot more uninsured people, and this is going to increase our uncompensated care costs. And we're already at about $500 million of uncompensated, unreimbursed care costs for hospitals. So it just continues to add to that weight. So what we wanted to do was to give you an idea of what's going to happen is to take one hospital as kind of a case study. And so Mason Van Howling from UMC is going to talk about how it's going to impact his hospital.
Great. Thank you, Mr. Kelly. And good afternoon, Madam Chair and committee members. For the record, I'm Mason Van Howling, and I'm proudly serving as the Chief Executive Officer of University Medical Center. For those that may not know UMC, we started out in 1931 taking care of the workers of the Boulder Dam with one doctor and one nurse. And then fast forward to today, UMC is the largest public hospital in the state of Nevada, the only magnet hospital and the largest academic medical center. UMC serves about 500,000 patients on an annual basis, whether they're in our primary care, our quick cares, which is our urgent cares throughout the valley, online care, our specialty care, and then also the main hospital acute care services. All those services are trying to keep patients out of the hospital so we can reduce the cost of care in the valley. Typically, I'm here to talk to you about our clinical services, but today I'll be talking to you about some of the financial operations of UMC. And as Mr. Kelly mentioned, HR1 is certainly going to have an impact on UMC, but every hospital in Nevada will be impacted in some shape or form. Just a little bit about our payer mix. This is our inpatient payer mix. As you can see, 42% is Medicaid, which has been described as a program for low-income family, children, and disabilities. Medicare, which is a federal insurance program, usually based off of age and disabled under 65. At 4% is our governmental payers. That's typically our veterans and our military and our TRICARE. All that and the remaining is commercial insurance, which is typically your employer-based insurance, self-funded. And then UMC has experienced about 5% self-pay on our inpatient business. When you add in the governmental payers, that equals about 78%. So you can see that we're very heavily reliant on government reimbursement. And certainly that dependency shapes how we operate both financially and clinically. You've seen this chart in the first couple of slides. This is Clark County and 622,000 enrolled in Medicaid and the two different programs. Clark County is about 2.4 million in population. So that 622 equals about 25.9% of the overall population. And just on a national basis, Medicaid program US-wide is the largest single source of healthcare coverage in the United States. As Mr. Kelly mentioned, we're talking about supplemental payments beyond the base rate of Medicaid, which is kind of the enhanced rates. UMC through FY26 year-to-date actuals, we have about $769 million in patient revenue. $261 million of that is the supplemental payments that come in at UMC. So you can see how vitally important the supplemental payments are for as part of our overall net revenue, equaling 34%. This is a little bit of a complex slide, but it's really about the history of supplemental payments at UMC, kind of showing pre-ACA, before 2014, how we were in a disproportionate share program. The expansion of Medicaid, and Nevada took a bold move, the right move back in 2014 to expand Medicaid. For years, we operated in this disproportionate share. We opted out of DISH in 2022, FY 2022, because it really limited the county and the state on the amount of dollars that they could accept from the federal government. So we moved over to the state-directed payment programs, and then that's where we started experiencing our reimbursement at Medicare rates, but very short time. Then we moved to average commercial rates, which Ms. Weeks talked about early on. As you can see, that was really a game changer for us. After 2022, that last hash marks, we started experiencing a higher reimbursement, which we've been able to reinvest in our community in response. The next slide is really, this is a hypothetical slide. So this is not UMC today, but what we did is kind of taken a look back to FY 20. UMC was clipping along, meeting budget, positive cash flow until March 2020 hit. And then this is what pretty much every hospital in the nation experienced. But then we rebounded in FY 21. And then what we've done is just layered in the Medicare rates for our state-directed payment programs. And as you can see, both our income from operations and our EBITDA are below budget. And these are in thousands. So you can see 20 million, 40 million, and then over 80 million. Next slide is just kind of us projecting. Our financial team took rate reductions beginning on January of 2028 on the state-directed payment program. So this is a 10-year phased-in approach every year, 10% compounded. So in FY 28, UMC starts seeing taking out of the financial system of UMC 4 million, and another 10% the following year, 12 million, until you go all the way to 2038, 83 million, and that will be the dollars that UMC will have to operate without in our largest public hospital. This story, I will be frank with you, is unlike, it's the same story that you'll hear in Alameda Hospital, which is a safety net hospital, Denver Health in Colorado, Parkland in Texas, Jackson Memorial, Grady in Atlanta. So this story is the same throughout the nation. And just as a reminder, as Mr. Kelly mentioned, Medicare rates are really only cover about 83 to 85% of the cost of care for all hospitals in Nevada or in the country. So again, that reduction, we're still gonna have to make things up even at Medicare rates. Becomes very difficult for UMC. We did talk about non-citizen and undocumented patients. I just wanted to highlight this. This is a slide of what we're experiencing at UMC. Medicaid emergency Medicaid for patients that are undocumented or non-citizens represents about 6% of our overall discharge. But interesting enough, it's about 14% of our Medicaid patients. So again, a patient segment that all hospitals will have to take care of in Nevada. That for us is about $6 million a year on top of what we've got to figure out how to make up the difference. And to Senator Donate's comments about more patients uninsured, but also less money to do that with. So it becomes a challenge for our safety net hospital. You know, there is really our commitment is our mission at UMC. That really is what drives essential hospitals such as UMC throughout the nation. We are very driven on accessing high quality care. And that's really what our foundation is as a safety net hospital. But as you can see in some of these bullet points, our ability to bring some of these community services that fill some of the health gaps, some of those life-saving services, GME is vitally important to us, our state, as you all know. And then population health care. That's where we're reaching outside the walls of UMC and trying to influence social and economic influences on healthcare to drive down cost of care for the state. We've mentioned that, you know, the behavioral health impact, and I do want to compliment the state and the health authority for making excellent strides on addressing mental health and the access and the cost of care. But that's certainly something we're going to have to address, and you've already started to think about that. I do want to personally say thank you, and on behalf of the Nevada Hospital Association as well, Thank you all in the legislature, the Patient Protection Commission, the Health Authority, the Hospital Association, the American Hospital Association. HEALS has been very active, and many, many others, our federal delegation, all our physician and nursing out there that are working together to solve the problem. With that, I'll turn it back to Mr. Kelly.
Pat Kelly, you asked what would be the likely impact to Nevada hospitals. So we wanted to put a couple thoughts out there. One is emergency departments are probably going to see the biggest impact because we're going to see increased ER utilization, longer wait times, and more non-emergent visits because people are not going to have the health care to go see a primary care provider. The financial impacts, we're going to see rising uncompensated care, more self-pay patients, and most of the time self-pay patients mean very low or no pay patients, and that's going to put pressure on the hospital margins. So what options will be out there? People always say, well, what's going to happen? Well, you know what? I don't know. And I think that every hospital is sitting there waiting to see exactly how much money it's going to be, how it's going to impact them before making any final decisions. But everybody has to start thinking things through. So here are some of the options, and that is reducing or eliminating services, cutting some staff, delay the replacement of equipment and other investments. And a lot of people say, well, that's not a big deal. Well, it is for this reason, because once you start delaying, replacing, and updating things, then all of a sudden, in a few years, you have major problems, that your equipment's not working, that your facilities aren't adequate. And unless there's going to be a big pot of money coming in the next few years, you're always going to get behind once that starts. And that's very dangerous. Closing facilities is always a possibility. But we need to start innovating and building efficiencies to shape the future of healthcare. So, AI could become very important and a way to minimize some of our costs. So how can the legislature help? Well, we talked about the base Medicaid rates. There's always an opportunity to increase those. Reducing administrative burdens. It's just amazing to me how much we spend just to collect money for the care we provided. And it just doesn't make sense. And then improving the sharing of healthcare information is important. We'd ask you not to pass any laws that's going to increase the cost of healthcare. And one of the big ones out there is mandatory nurse staffing ratios. It's a huge amount of money. And don't pass any laws that unreasonably restrict the cost benefits of AI in healthcare. I know there's a lot of talk about AI. People are concerned about it. But please go gently here, because there are going to be opportunities for us to use AI that will save money and improve the delivery of healthcare. So Mason's already kind of gone through this, and thank you. But that is and this is Blaine's slides. I made him go first because he had to leave. So we'll just go on to questions. Thank you.
Thank you. Thank you for your presentation. We appreciate that. Members, questions? Okay, we're going to go up north. We'll start with Senator Titus.
Thank you, Madam Chair. Much appreciated. All three of you, I very much appreciate all of your perspectives, having lived and breathed it my whole career. One of my questions, Mr. Kelly, is your comment in that list you had about how you're going to survive and what's going to happen and the impact on self-pay patients. I'm one of those self-pay patients. I have Medicare A and B, but no supplements. And so I want to go in and I pay for my portion of my care. One of the things that we're trying to do, and one of the things I know this body and federally, we're looking at price transparency. So when I go to the hospital and I have to pay my cash for that, are we making any progress on the transparency and what it actually costs and what my bill is going to be for those of us that will be impacted by this?
Thank you for that question, Senator. So, there was AB 343 was passed last year, and it requires us to put a bunch of information up. There's a lot of questions regarding that legislation and how to report it, but it'll be up there. We're already in compliance with the federal law. The state law just goes a little bit faster. But one of the things about this whole price transparency thing that I don't think people quite get is that it really doesn't tell you what you are going to pay, because what you're going to pay depends on the type of insurance you have. So we put out the information on standard charges, but mostly no one pays that. And even if you did pay that, you get 30% off of that under state law. So if you have Aetna insurance, the real answer is, what deal did Aetna do with the hospital, and what's your deductible? That's what's going to come down to driving what you pay. Looking up and just seeing that standard charge isn't going to tell you what your liability is going to be for having that service performed.
Follow up, Madam Chair. So along that same question, are you doing a better job about letting patients know that this is your hospital charge, but hey, heads up, you're going to be charged by the radiologist, the person interpreting the x-ray, the lab charges, plus the lab, the pathologist, and all of those. So I think people get very confused sometimes about that transparency of what a cost really is. Like, this is X, but oh, you're going to have all of these other things added to. How are you navigating that information?
Madam Chair and Senator Titus, Mason Van Houweling for the record, and I'll speak to what UMC is doing, but also typically every hospital in the state of Nevada does. So certainly there's two types. If we know a patient's coming in and it's elective business and scheduled, as you know, very well know, we have time to be able to figure out what that pricing is going to be and what type of procedure code. And so we can give availability of that pricing. Every hospital has financial counselors that help patients navigate the system, whether it's seeing if they qualify for some of the Medicaid products or any of the charity discounts that our hospitals offer, but also trying to negotiate a price that's affordable and set them up on payment arrangements. When it comes to the inpatient side, obviously, things move very quickly, but all of our financial counselors in our consent for treatment do disclose that to the patient that, hey, we also have partners, whether it's a radiologist, the ER physician, or your specialist, and that some of those, whether they're employed or not, or partnered, we do disclose that to the patients that they will get additional bills. And then often if there's elective business, we'll try to connect them prior to so they can work those discounts with their partnership. But again, we're always trying to see if they're eligible for something, whether it's through the exchanges or some of the Medicaid products or some of our uncompensated care discounts throughout the state.
Thank you for that. I just remain very concerned about throughout this morning, we've heard about the possible increase in individuals' medical debt, and that's something as a nation I have concerns about. Our nation has concerned about, and worried about some of these programs actually increasing patient medical debt. So thank you for that, and hopefully we'll see a little bit more clarity. Thank you. Thank you, Madam Chair.
Thank you. Next, we'll go to Senator Donyate.
Thank you, Madam Chair. And thank you for the presentation. I want to dive, first and foremost, thank you for the recommendations. I'm going to come back to them. I want to dive deeper so that the public understands the ramifications of HR 1 in terms of what are the specifics of what's going to, it's not a potential scenario, like this is going to happen. In one of your slides, you mentioned that there was going to be closures that could potentially occur because of the passage of HR 1. For my it's my understanding that traditionally, when we look at services that hospitals would close, right? I think there's conversations to be held with rural hospitals. I'm gonna put them on a different bucket because I think they operate in a very different peculiar situation because of a patient volume, right? I think I'll come back to Boulder City in a little bit, but it's my understanding that generally for most hospitals, or most acute care hospitals, when you are looking at how do you make the budget make sense based on, and I'm looking at you, Ms. Van Houweling, how do you make the budget make sense? Oftentimes, as administrators, we look at the services that often do not have the revenue in place to self-finance them, right? It's the critical services that we do because we need to, but oftentimes the volume might not be there or so forth. And so traditionally, what I've seen across the nation is that the types of services that we end up cutting are outpatient facilities, inpatient psychiatric beds, behavioral health, maternal fetal medicine, high risk obstetrics, diabetes, or chronic care management, dental clinics. Sometimes some hospitals have dental clinics or ancillary services. Is it a fair judgment to say that all of these could be potentially at risk for being cut, depending on the hospital and the situation, to be able to meet the revenue goals that you have?
Thank you for the question, Senator Pat Kelly. You're right. When you look at it nationally, when programs have decreased, it's usually behavioral health and maternal related services, because they are heavy intensity in the resources that are needed, and you often don't have the volumes to be able to justify that after a while. So those are looked at. And I think that I'm not sitting here, I don't want to alarm everybody. I'm not saying that hospitals are going to close because of this. What I will say is that hospitals don't close for any one reason. They close because there's a multiple set of things that are occurring, and it just becomes overwhelming for them. Or they have to make the changes you were talking about, Boulder, or referring to Boulder. They went to a rural emergency hospital. And I'm sure part of the decision was looking at, they're part of the provider fee program, that's going to decrease. So I'm not saying that happened because of the decrease. What I'm saying is that when you're looking at everything as a whole, you start to judge where you need to put that institution so that it will remain and be able to service the community.
Madam Chair and Senator Donate, Mason Van Halen for the record. I think, Senator, you absolutely hit some of the high points related to how you look at services and how you're operating. And I know your background is well astute to this, but those are the things you look at. For example, we post-pandemic did a lot of things, but started looking at how can UMC help solve some of the behavioral health problems. And we've opened up a crisis stabilization center with the support of the state and the county and UMC coming together. Those are all things kind of at the top of mind for healthcare executives. What's the rate of growth of that? Are we going to perhaps continue those type of things across the state of Nevada? So I certainly think your list are certainly ones that every hospital in the state of Nevada is thinking about. And we want to work with everyone to be able to ensure those services and not unwind and go back to pre-2014.
Yeah, thank you, Madam Chair. May I follow up?
Please.
Thank you. Perfect. So, and the reason why I was asking that is, Mr. Kelly, you hit it right on, right? A hospital, when this hospital decides to close either a service or the facility themselves, there could be multiple reasons. Obviously, HR1 could have been a catalyst for certain closures that are currently happening or will be happening just by the nature of the revenue shortfalls that we're going to reach. I think that's just a general something that we have to accept. I want to make sure that as lawmakers, you are making sure that you are briefing us before those closures are occurring. Because if we can utilize the rural transformation dollars or the public option pass-through funds or general fund dollars to make sure that those that maternity ward or those services are protected, I want to make sure that we are the first ones that you call and that the funds are available for you, right? Before we start funding GME, before we start going into all these different pots of money or allocations, I want to make sure that we protect what we already have. And I cannot implore you enough that we have to have that level of routine communication both to state lawmakers, because I don't want us to be a year from now and you're telling me that the city of Elko and their hospital is closing their maternity ward because they had a funding shortfall of $2 million when we could have used the rural transformation funds to help supplant that. And so I want to make sure that we have that level of commitment from you. The only other thing that I would, and perhaps you can ask, I understand the rationality of administrative burdens. I know that it's difficult having to fight with the insurance companies as to why patients need their adequate care. As much as we can implement AI and we can try to reduce the burdens for our hospitals, we still run into the same issue, which was my question earlier, which is how are we going to solve the coverage gap for the people that are going to be a part of the missing middle? And so I just want to make sure that I can maybe, if you can give me some feedback, that the hospital association would be supportive of using the pass-through funds to help cover the missing middle for the people that are going to be displaced from Medicaid. I don't want to be in a scenario where the hospital association is advocating against that. And certainly, I think that we should work together. I mean, if there's any other ideas that you can think of on how to solve that coverage gap, I would love to hear your perspective. But I want to make sure that you're also helping us solve that crisis that we're going to be facing pretty soon.
Senator, thank you for making those points. Pat Kelly, for the record. We are always committed to working with you on different things. I mean, that coverage gap is going to impact us as well, because if those people aren't insured, they're going to be uninsured and come in, and we're going to provide care for free, and that's going to be a burden on us. I'm not sure what you mean by the pass-through funds, but you have my commitment that we'll work with you on that. And just one thing, I'm more than happy to tell you when something's going to happen, the service is going to close, but usually I read about it in the newspaper. I mean, I don't get that information in advance from a lot of the hospitals. And one of the reasons I don't get that information is they're worried about it getting out into the community too soon, and that then the nurses start leaving and different medical professionals leave. So there's usually not a bunch of advance notice. I mean, there was just one service that closed that I read about it in the newspaper. So if I know about it and I can come to you, I will be happy to do that. But just please know, I don't always know in advance of this happening.
Thank you. I believe the senator was referring to the public option as the pass-through.
Oh.
Yes, just for clarity. We have one question from Assemblymember Nadeem.
Thank you so much, Madam Chair. I want to ditto Senator Dante concern and his what he just said, that we are here to help because the concerns the hospital association is telling us, it is very concerning, and we are there to help. All the legislatures, we want to work with the Department of Health, we want to work with the governor office, how we can help it, how we can make it more affordable and accessible, because this is affecting the lives of all the Nevadans, and we are there to help and make it better. Thank you so much. Thank you.
I do have one additional question. I know that Mr. Osborne, Assemblymember Osborne, has moved on relative to the rules, so I'm just going to go with new hospitals. We do know, and I asked the division earlier to talk a little bit about the Intermountain Health, and not to just identify Intermountain Health, but there's a new hospital bill that's projected in Southern Nevada. That is the Children's Focus Hospital, and I'm curious to know if you have any idea relative to the change in the provider tax and what that does when we're looking at a new hospital build. What's the sustainability of a business model in that way? I don't know if we have anyone from Intermountain Health that's here that could speak to what does that business plan look like, but I just want to make sure that I ask that question, and I don't know if you have any response to that.
Pat Kelly, for the record. Madam Chair, the Intermountain is not yet a member because you have to be a licensed hospital to be a member of the association. But I think as a practical matter, they're going to see a lot of Medicaid patients at that hospital. Those kids are going to be, I wouldn't even be surprised if a half or more of their patients were Medicaid. So yeah, it's going to have an impact on them. And that has to be concerning to them. I mean, obviously they're moving forward and everything, but that has to be concerning. And I've actually sat back and wondered about that myself.
Thank you. And then just one last final piece that I'd like to get out there for Mr. Assemblymember Osborne. With regard to the Rural Health Transformation Program funds, we know that they're only going to last for 5 years, right? So, and we're not supplanting funds. So we're doing, good programming in order to enhance the support services that we're doing in the rural area of our state. I'm curious to know if those funds ending would then increase the likelihood that rural hospitals would face closures or cuts as a result. I'm hoping that is not the case, given that we are not supplanting things, but that we are building out new programs. But I'm curious to know and look forward to following up with Assemblymember Osborne and the rural hospitals in particular. Okay, it looks like we are done with questions. Thank you so much for this presentation. We appreciate you being here. We will officially stand in recess for the next 30 minutes. We'll be back at 1 o'clock this afternoon. Thank you.
Okay.
Oh. Okay, we're officially back from recess. Thank you. I hope you enjoyed your lunch. Okay, we are all present and accounted for and ready to move on to the next agenda item, which is number 2 of item 5, the Primary Care Association discussing the impacts of HR 1. Thank you. Thank you. We will stand in a brief recess until we find our presenter. Thank you. Welcome. Thank you for joining us. You are welcome to begin whenever you're ready.
Nancy Bowen, for the record. I am the CEO of the Nevada Primary Care Association. We are the association for the federally qualified health centers. And we also actually work with lookalike organizations and what are FQ8C tribal organizations. So it's been a while since we sort of went over what a FQ8C is. So we want to do a quick 101. So what is an FQ8C? It's a federally qualified health center. They actually receive federal funds to do comprehensive care in medically underserved areas. You've actually heard them called MUAs. They're designed to serve Medicaid and underinsured patients and uninsured patients. That was the whole point as they started back in the 60s. And you'll see by the percentage of numbers of what our FQ8Cs serve that how important that really is. One of the big features of a FQ8C is that they have to serve patients regardless of ability to pay. So they have a pretty high uninsured rate. And so no matter what, patients get care, whether they can pay for it or not. Thank you, Steve. The majority of a board for a health center is 51% patients. That's the bare minimum. A lot of our health centers actually have boards that are all patients. So they typically have a board of like 10 to 11 individuals. They are all nonprofits. So their patients are serving on their board. Some of their board members are patients, most of them are, and that really helps with the governance piece so that they understand the health center and all that is involved. Each health center has to have a sliding fee scale that goes from 0 to 200% of the federal poverty level. Right now, when I looked it up, the federal poverty level is about $66,000 for a family of 4 for a year. Not a lot of money. And each health center has to provide integrated care. So they start off with primary care, and then they add on behavioral health. We have a couple that do dental or oral health services, and of course they do care coordination services. So this is the network that serves Nevada. There are 8 Nevada-based health centers. There are about 4 that come from California, 1 from Arizona, and then we have 2 tribal health centers, which are FQ8C tribal health centers. And this is the map. So you can see all of the health centers, the majority of the health centers are based in the urban areas of Washoe County and Clark County. There are some in the rural Clark County, and then you have some in other counties. It's a challenge. I mean, 80% of our population or 90% of our population is in the urban areas. So the health centers are located in the urban areas. And who do we serve? So we have 2024 data. Our 2025 data is still being analyzed. Back in 2024, the Nevada-based health center served over 128,000 Nevadans, unique Nevadans, with about 428,000 visits. This was done at 62 clinics and 12 mobile units. And as I mentioned earlier, the patient population is 88% of those patients are 200% of the federal poverty level or below. So that's, that leaves 12% who are actually 201 and above. And about a third of the patients are served in a language other than English, which speaks to the diversity of the communities that we serve. And so that uninsured and Medicaid rate is about 69% of the patients that the health center serves. So 30% of those patients are uninsured. And you'll hear later on how we anticipate that that number is going to go up. That's 5 times more than the national average for a private practice. And 39% of those patients are on Medicaid. And that's about twice as a typical physician practice. Their patients typically are very, very ill or very sick. We hear that a lot. This is typically due to lower income than average. The patients have a lower income than average. They're more racially and ethnically diverse. That speaks to the language being 1/3 being served in a language other than English. More are likely to be unemployed or uninsured. Again, poor health, and we have higher rates of chronic disease. So 50% higher for asthma and hypertension. Chronic disease management about diabetes is another big piece that the health centers provide care for. The care that they do provide is really high quality. 50% of the health centers are what is considered a patient-centered medical home. We do have another one that is actually going to be recognized, planning to get recognized later this year. So we'll have 6 of our 8 Nevada-based health centers are patient-centered medical homes. When you compare the patients to their peers, low-income individuals who don't go to a health center, children actually get a regular checkup and dental visit each year when they come to a federally qualified health center. Adult patients receive regular cancer screenings, and the chronic disease conditions are managed. We actually have a peer network of the health centers that work together, and they've been working in this last year around diabetes management and increasing the controlled percentage. And the data shows that they were able to increase the patient control of diabetes by 2.7%. And so we hope that keeps continuing to go up. And who do we serve? Well, typically our patients are, they have unpredictable work hours. They're, day labor, babysitting, housekeeping, gig type jobs. That's not always captured in the automated wage information. So our health centers usually have extended hours so they can meet the patient care when the patient can come in. And I'm going to pass it over to Steve Messenger. He is our policy director, and he's going to go over the remaining slides.
Thank you, Nancy. Thank you, Madam Chair. Steve Messenger for the record. So when we're asked to look at what it's going to happen from HR1, we're really, like the hospitals, like Medicaid, dealing with a wide range of uncertainty because we haven't had this guidance that we keep talking about coming in June. So basically, we're looking at $6 to $11 billion in losses as our working sort of number. We have been working with Nevada Health Authority and other stakeholders to minimize that loss coverage, but the bill is designed, basically, this is where we start from this analysis. If they're going to get $1 trillion of cuts over 10 years, Nevada's share of that is about $6 to $11 billion. So Nevada Medicaid is the largest funding source for our FQHCs. Nancy mentioned that about 30% of our patients are uninsured. Almost 40% of them are on Medicaid. That's really our bread and butter. We're one of the few provider types that is designed to get cost-based reimbursement for Medicaid patients. Basically, everyone else will tell you that they lose money for seeing Medicaid. This is our biggest funding source. The other being a discount drug program called 340B that we'll talk about in a little bit, and then only about 11% from our community health center grant from the federal government. Just to put that in context, that grant's about $24 million across the 8 health centers every year. It's been that way. I think we got a 4% raise in this last cycle, but it's basically been that way for a long time. So we estimate that about 25,000 patients could lose coverage at our FQHCs. We believe that we disproportionately serve that expansion population. We believe that based on the effects that the Affordable Care had on us. But about 48,000 of our patients were covered by Medicaid in 2024. We know about 38% of them are children and not subject to the changes in HR1. And so if we exclude the disabled patients and those in prenatal care, that leaves us about 25,000 that we think we're going to be working through with work requirements. Because we don't know the federal, state rules yet, again, there's wide variation. Some studies say that we could lose up to 72% of that work requirement eligible population, down to about 36%. So a midpoint of 54% implies about a $17 million loss per year, or about 11% of our operating revenue. I want to get back off the numbers and think a little bit about the patients here and the people that we're really serving. We know that cost shifting is not cost saving. Somebody I think mentioned the health economy balloon that you squeeze on one side and it pops on the other. We really believe strongly that preventive primary care is the most cost-effective investment in population health. We consistently see studies that look at FQHC and the outcomes that they have. And it's for the last 30 years that they've been doing these studies, we know that the comprehensive approach we have saves the system money, saves Medicaid money, saves private insurers money. We prevent costly hospitalizations by managing chronic conditions upstream, and it's much better for the patients and the providers and the finances of the entire system if we do it there and not in the emergency room. So reducing Medicaid coverage does not eliminate costs. It shifts them to the emergency room, which cannot turn patients away. Those uncompensated costs are passed on to Nevada employers and privately insured families. And I'm not sure that we have really explored this idea yet. I know the hospitals don't want to talk about, what they're going to have to do to recoup their costs. But at the end of the day, there's only so many payers who are able to pay. And that's your private insurers. That's your employer's premiums. And that's your employee premiums as well. And that's where we would expect a rise in uncompensated hospital care to show up for the rest of us. We know for an uninsured patient, a primary care visit that identifies a serious condition becomes a dead end. A diagnosis without a treatment pathway. This is Nevada has always had one of the highest uninsured rates because of our demographic population. And it's one of our biggest challenges of our health centers. We're constantly doing cancer screening. And if you find cancer as a provider in a patient who does not have insurance to go on and see that specialist, it's traumatic for both the provider and the patient. A lot of them will feel like they were better off and their families were better off not knowing that they had this big, expensive, looming problem. And that's not how we want anyone to have to feel. So how will FQHCs respond if 13,000 patients that are estimated to lose coverage and remain within our FQHCs? That would take the share of uninsured patients to 40% from 30%. Our members tell us that is not something that they are able to do with their current arrangements, their current costs. So without a replacement in Medicaid reimbursement, we could see overall services drop in line with the increased share of uninsured. So this is basically the pot just getting smaller for everybody. We can't afford to keep seeing so many people that are uncompensated, so we end up seeing fewer and fewer people overall. An 11% revenue reduction translates to an estimated loss of 107 full-time equivalent jobs across our FQHC network. And it's not just HR1. We've had financial pressure from, we've been cutting to the bone like the hospitals have said similarly for many years. Our federal grant has not kept up with inflation. We had 10.6% growth in funding between 2019 and 24, compared to 19% growth in patients, and about a 26% growth in visits. So we're growing visits about twice the rate of patients, and we've been doing that for years. So we know we're already got our efficiencies ironed out. Our 340B revenue has also been shrinking. This body has taken efforts in the 2023 session to ensure that health centers that are entitled to discounted 340B drugs can't be discriminated by payers. So if just because a payer knows that we got the drug for less, doesn't mean that they can pay us less. And we thank you for that. That was an important first step that almost all the states took. Most of the other states have also gone further to ensure that their safety net providers can continue to distribute those discounted drugs through a network of contract pharmacies that expands the reach of the program as far as possible, both to allow for the patients to get low-income drugs in their neighborhoods, but also to allow for the health centers to bill for drugs to privately insured patients, in their neighborhoods as well, and also reap the benefits of that, which is, again, one of the three legs of our stool. So some ideas for relief. We always talk about 340B as being, kind of the closest thing to a free lunch as the legislature can see. As I said, it's worth more than $30 million a year for us in non-taxpayer money that is propping up your safety net. That's been eroding at a fast pace, and we could actually do more to regrow that pot. So we would encourage you to look back at a bill that this particular committee approved in the last interim that was never introduced in the legislative session. Our members have also been telling us that they could use some property tax relief. One of the benefits of a health center is that it's located near where its patients are. In downtown Reno, that means that it's located right where there's a bunch of casino development and condo development happening all around it, making the land that those health centers are on very expensive and starting to be taxed at a rate that's, profound for their budgets. So there's more than $1 million of relief that could be passed on that, again, would go straight into community safety net services if we just allowed FQHCs to be exempt from local property tax. And we could go even further if you were to get creative and make something like a transferable tax credit that could allow the renters to also see some benefits. In Las Vegas and Southern Nevada, there's going to be a lot more health centers that are, part of some rental property than there are in some of the rural or northern areas. So we really think that could be a big benefit both to the landlords that rent to those health centers and to the health centers that could get lower rents and plow those savings right into services. So we must decide whether uninsured residents receive care in costly emergency rooms or cost-effective FQHCs and fund accordingly. And we ask this committee to champion FQHC investment as the smarter, more humane option. And we will stand for any questions. Thank you.
Thank you for your presentation. We appreciate you being here and sticking with us through lunch in particular. Questions? Assemblymember Hibbets.
Thank you, Chair. I'd like to go back to slide 13. At the very bottom, it says, excluding disabled patients and those in prenatal care, we estimate nearly 25,000 expansion patients who will be subject to work requirements. And then fast forward to number 17, you estimate 13,000 patients will not be able to, I'm paraphrasing, 13,000 patients will lose coverage, I'm assuming because you believe they cannot meet those work requirements. Why do you have such little faith in our citizens?
Thank you for the question. Steve Messenger for the record, Madam Chair. Well, we've had experience with this. We have case studies that happen in Arkansas, Georgia. We are very much just following the experience of the states that have tried this. And also, as federally qualified health centers and as a primary care association, we're lucky to have lots of friends across the entire country. So we have peers of both of our health centers. There's health centers that are very similarly resourced and sized, and we have primary care associations that have worked on these policies. Despite their best efforts, that's the estimate, the experience that we've seen in the past. So purely going by the experience of other states.
Assemblymember Nadeem.
Thank you so much, Madam Chair. I just want to clarify when you said there's a deficit of 6 to 11 billion regarding the Medicaid cut, regarding the healthcare cut. Is that over the years? How many years?
Thank you for the question, Assemblymember. Madam Chair, Steve Messenger for the record. That's based on the CBO estimate of HR1. So they were able to get $1 trillion of savings over a 10-year budget period of $1 trillion. The 6 to 11 billion is Nevada's share of that.
Thank you. Next, Senator Danyate.
Thank you, Madam Chair. Thank you for the presentation. For the sake of time, I'm not trying to belabor the same points that I made earlier, but I just want to make sure that I at least have a clear understanding of the financial health of some of your members. Do you have any estimates or right now in terms of any services that could be potentially impacted or like a gross estimate of perhaps let me rephrase my question. There are going to be, as of date, I'm sure that you probably know of some members or some clinics that could possibly be on the verge of closing. And so do we have an anticipation of how many clinics could be potentially impacted either for a potential closure or a reduction in services based on the implementation of HR1?
Thank you for the question, Senator. Steve Messenger for the record, Chair. I think that we're with everyone else. We don't know exactly. We would look to, again, the points that you made earlier, the most loss leading sort of services. One of the things that we've been struggling to expand for many years is adult dental, and we've kind of finally got some of the policy and financing pieces in place. But that's still always been a loss leader for the health centers, and so that's something I would expect to continue to get kind of shrunk. And it's all about sort of they shrink the capacity, and that effectively shrinks the access. So I don't have a number of patients to give you, but I can tell you they're going to look at the service lines that aren't making money. So if their behavioral health is not turning a profit, is that something that they have to cut? Pretty much all the health centers have more than one site. So you could very much see them trying to think about, consolidating their resources. If they ask their patients to drive a little bit further, they can save some money on rent. They have a little bit smaller staff, but try to maintain a similar capacity. That's what I would kind of expect the moves they would make.
Madam Chair, if I may follow up. So the reason why I'm asking these questions is, I think we both have had the discussion of how I've worked in primary care. Some of my health centers that I managed had a level of care navigation services. It's my understanding that many FQHCs have community health workers or care navigators that meet with patients to help them enroll, but they don't bill, right? A lot of that comes from the institution feeling that it's a service that we have to provide to our members, right? Because that's what they expect of us. And so it's a fair assessment based on my understanding that those are going to be the positions that are first cut, which are ultimately the people going out into the frontier and rural areas. Is that not correct?
Thank you, Senator, for the question. Steve Messenger. Absolutely. Anything that's not producing a revenue is going to end up being a cost. And so for them to focus on the mission that they see as most core, those are exactly the kind of services. We kind of think of it as the special sauce of what makes a health center a health center. And that is the fact that they are able to really provide those wraparound resources, navigation, not only to kind of the health literacy, but also to the social services, addressing the social determinants of health. And yeah, that's all expense. So I would expect a reduction in those services.
Thank you. The only comment, Madam Chair, that I just want to make is, one of we've worked so hard as a state to help uplift our community health workers, and I hate for us to take a step backwards. But there's a lot of things that are going to be impacted by this. We didn't even touch on the point of, obviously, earlier we heard the cuts towards immigrants, right, that are affected from the passage of HR1. Many of your FKHCs support that community. And so I think it's going to be a very daunting task to be able to solve this crisis. And so any ideas that you would have in the interim, please communicate them to us. Talk to your members in terms of, you presented some today in terms of temporary relief on property tax, but I don't think that's going to be enough to support the members and the patients that come to you. So please help us solve the coverage gap issue, because it's going to be the most pressing issue that we have to face.
Thank you. Just one clarifying question. Following up on Senator's point, would those community health workers have the ability to apply to become navigators and then create a funding stream for the FQHCs? Is that something that you've considered, or is even possible?
Nancy Bowen for the record. Thank you for the question. Yes. So right now, some of the community health workers are reimbursable for some services. Our health centers would love to be able to have navigators and to do eligibility screening at their health center and actually be enrollers for Medicaid at their health centers. Right now, they do have eligibility screeners, but it's a challenge. Like the Medicaid employee has to come out to the health center. We would love to be able to do that ourselves.
Thank you. I believe you have a phone a friend directly behind you. Would you like to come forward and give us some information specifically about the navigators?
Thank you so much, Jennifer Krupp, for the record. I am the administrator of the Division of Consumer Health Services. So we will be releasing an RFA on Friday to help support community navigators. FQHCs would be eligible to apply, and we are very interested in working with many of our federally qualified health center partners. I've worked in many of the programs that you guys are describing in the past, particularly with having community health workers in place within the FQHCs. And so that is how, as we're designing this program, looking at how we can help assist in many of those areas and help connect our Nevadans to coverage. So thank you.
Thank you for providing that clarification, Ms. Krupp. Thank you so much for being here and our expert witness. We appreciate that. I see no other questions. Okay, no additional questions at this time. Thank you so much for being here and presenting this information. We sincerely appreciate you. We will close this agenda item 5. And move on to agenda item 6, which is the presentation on the impacts to nonprofit organizations made by HR 1 and federal changes. Understand we do have a presenter up north. I believe we also have a presenter online, remote. Oh, there she is. Thank you. We appreciate you both being here and presenting this information. And you may begin whenever you're ready. Oh, we have 2 online. Thank you. Thank you so much. Go ahead and begin whenever you're ready.
Thank you so much, Chairwoman. Can everyone hear me okay?
Yes.
Thank you. My name is Janet Quintero, and I serve as the Chief Strategy and Advocacy Officer for United Way of Southern Nevada. I want to start by sharing a thank you to Chair Brown-May and members of the committee for the opportunity to share about the impact of HR 1 and other federal actions to the nonprofit sector. I also appreciate the opportunity to join via Zoom, as I'm currently in DC for United Way's Advocacy Forum and Capitol Hill Day. So thank you for the flexibility there. I'm grateful to legislators for the close partnership and the close partnership with state agencies as we navigate these changes together. I am also very proud to be joined by Executive Director Jill Tolles from the Gwen Center and Mark, who will be co-presenting with me. During my presentation, I will focus on some areas that United Way has addressed and how nonprofits have navigated changes that began in January of 2025. And again, this partnership with the Gwen Center will allow for a deeper dive into the data. The mission of United Way of Southern Nevada and nonprofit partners is to serve low-income and moderate-income populations, and to use Senator Donate's term that he used earlier today, that also includes the missing middle. United Way focuses on youth opportunity, financial security, community resiliency, and the nonprofit sector. I'm not sure if you have slides. I'm not seeing that on my end. But if you do, you will see that we have 4 core areas of impact, and a 5th one that includes nonprofit sector sustainability and supporting the sector as a whole. That means that all the topics addressed today fall within one of our impact areas. To that extent, HR 1 and federal funding changes impact our community. United Way is committed to be a convener and to make data-driven decisions powered by key partnerships like the one today with the Gwen Center, but also feedback from those impacted directly by these changes, whether that is by nonprofits directly or by the communities that they serve. I also similarly want to start by defining the scope of what these federal actions that are impacting the nonprofit sector are. In addition to HR 1, as of April 10th, there are 57 executive actions or orders impacting nonprofit organizations. That is in comparison to 42 executive orders or actions that impacted the nonprofit sector in April of last year. So in addition to HR 1, the nonprofit sector is actively navigating these changes that impact not only our mission, but our operations and the way that we manage grants. As a quick look back, I do want to share that on February 25th, 2025, United Way had the opportunity to present an overview of federal funding in the nonprofit sector to the Joint Committee. That was over a year ago. And at that time of the presentation, we were responding to the OMB memo, which resulted in paused funding for key social service programs. As a quick look back, as of January 27th of, again, 2025, the Office of Management and Budget released a memo that required federal agencies to identify and review all federal financial assistance programs and supporting activities consistent with the President's policies and requirements. We know that that resulted in mixed action from different state agencies, and we know for a fact that that resulted in paused funding or immediate funding to nonprofits. In staying with our commitment to convene the United Ways of Nevada, that means United Way of Southern Nevada, in partnership with our partner, United Way of Northern Nevada and the Sierra, hosted a rapid response call in partnership with Nevada Grant Lab with over 350 nonprofits and community leaders who joined as we learned to navigate the space together. By February 21st of 2025, United Ways of Nevada launched a survey and received 160 entries. Each entry was representative of a federally funded program. This was anecdotal information. We surveyed the nonprofits and we said, tell us how you feel, tell us which funding is being affected as of today. So again, it served as a temperature check of the impact of federal changes at the time. We knew that the top constituencies that were impacted by these changes were children, parents, seniors, and people with disabilities. When we presented to the Joint Committee on February 25th, we shared what we knew at the time, but also what we did not know. At the time, we knew that nonprofit partners or nonprofit organizations are key partners to the state in the delivery of social services. We also understood at the time the short-term impact of these federal actions. Again, last year, we knew that we did not understand the long-term impact of these actions, but now a year later, we can reflect back and use this data to continue making data-driven decisions. So fast forwarding to January 2026, United Way and the nonprofit sector have remained action focused by convening regularly and strengthening key partnership with state agencies. More recently, we hosted Deputy Administrator Cantrell to share about changes to SNAP with our nonprofit partners. We understand the importance of education and outreach, as I know it has come up a couple times during this hearing. And we want to support the nonprofit sector, wants to be a partner to not only legislators, but our state agencies as we continue communicating the changes to our community. So now 4 examples of how nonprofits have been affected. And again, these are on the ground examples, firsthand for United Way or from one of our partners. These only represent a small sample. Again, a reminder that there are 57 executive orders or actions impacting nonprofit organizations as of April 10th. The 4 examples that I'll dive into are SNAP, Medicaid, charitable deductions, and EFSB. So today you heard a lot about SNAP, so I won't really recap any of that data and information, but we can tell you that we've heard directly from nonprofits that they have seen a surge in clients seeking basic needs. But at the same time, they've expressed a difficulty in serving the communities because of fear of engaging with organizations, and that includes immigrant communities. I also want to say that United Way and our nonprofits want to remain a partner to our state agencies by offering our United Way Volunteer Connect platform as an option when community engagement or volunteer opportunities are required in maintaining the eligibility status for SNAP. The second example is the Emergency Food and Shelter Program funded by FEMA. This was not directly impacted by HR 1, but this program has been paused since January of 2025. This program has not been impacted by any formal federal action, but the board has not voted on releasing funding that serves the state of Nevada and Clark County directly. Since 2020, EFSP has helped more than 680,000 neighbors with $8.5 million in support for food, housing, and basic needs. The way this impacted our nonprofit community is United Way we launched the Emergency Assistance Fund to try to fill the gap or attempt to fill the gap, but we're only able to do this at a significantly reduced rate. Similarly, you heard today about Medicaid eligibility. So the impact to nonprofits, we are seeing nonprofits with a surge in clients seeking basic needs as individuals attempt to rearrange spending to accommodate increase in premiums or SNAP changes. We also understand that some Nevadas may forego coverage altogether, putting a strain on nonprofit providing emergency or preventative healthcare services. And the fourth area is changes to the charitable deduction. This was a section of the tax bill. We know that HR 1 imposes a 1% floor for the deduction for charitable contributions made by corporations. This creates limitations on the incentive to give to charitable organizations. And again, staying with data-driven decisions, we don't yet have statistical data on the impact of the charitable deduction, but whether directly or indirectly influenced by these changes, we have seen firsthand donations from corporate partners have been impacted. As you can see, federal changes pose direct and indirect impacts to the nonprofit sector and our ability to serve low and moderate income individuals in the state. We have already seen local nonprofit organizations affected by these changes, but most importantly, this has impacted the communities we serve. Ongoing public-private collaboration paired with responsive policy solutions is critical to supporting our community. As United Way, our request is to continue being a partner to legislators and to state agencies as you continue to design programs to support our community during this time. We believe the nonprofit sector perspective is not only complementary, but critical to finding solutions for our community. That concludes my remarks, Chair, so I will hand it back to you. I know that we have Executive Director Joe Tolles in Northern Nevada ready to join, but I'll hand it back to you. Thank you.
Thank you. We'll go ahead and move to the second part of this presentation, if you don't mind. Ms. Tolles, whenever you're ready.
Thank you so much, Chair. And I do have a PowerPoint. It's loaded up here in our sparsely populated Carson City location. Is there a way to have that thank you online for anyone watching? Thank you so much.
You can see it. Go ahead.
So thank you, Chair and members of this committee. My name is Jill Tolles. I'm the Executive Director of the Kenny Gwynn Center for Policy Priorities. We are a statewide, independent, data-driven, nonpartisan policy research center, and it is a pleasure to present to you today. I'm also joined by Mark Krompottek, who is one of the primary authors of the reports that we'll be discussing today. And I also want to thank you for spending time on this important topic and bringing in nonprofits, knowing that they are key service providers in our state and partners with the state of Nevada. Over the past year, our Director of Health and Social Policy, Piran Takis, and our Interim Director of Economic and Fiscal Policy, Mark Krompottek, published 4 reports addressing federal funding in our state with discussion of HR 1 and its impacts. The first was a standard report that we produce every 2 years, an analysis of the legislatively approved budget, which included an appendix on the impacts of HR 1 and considerations for this body. The second was a brief explainer on Medicaid and also including some discussion of HR 1.
and then 2 reports on federal funding in Nevada, which we'll focus on today. I want to make note that for anyone who's watching online, that all of our reports are available for free to the public at gwincenter.org. That's GUINCENTER.org. So in light of the shifts in federal funding, the research team sought to examine how much of the state's budget relies on federal dollars and where does that money go. So in April of 2025, the Gwynn Center released our first report on this topic with an overview on federal funding in Nevada, examining the top 5 federally funded state agencies: the Department of Health and Human Services, Nevada's Department of Transportation, Nevada's Department of Education, Nevada's Department of Agriculture, and the Department of Employment Training and Rehabilitation. And what we found is that 27.7% of the 2023 to 2025 biennial budget relied on federal dollars. That number, I'll note, rose to 28.1% in the current 2025 to 2027 budget. The largest share of those dollars in the last biennium, approximately 80%, were directed to health and human services, followed by transportation, education, agriculture, and employment training and rehabilitation, where many of our disability services lie. If you go to that report online or in front of you, in the appendix, you'll see that we provided a line-by-line item breakdown of the state and federal dollars by program, which proved to be an incredibly useful tool for lawmakers and the public as taxpayers just to see where those dollars go. Thanks to a grant from the Office of Federal Assistance, the team took a look at determining where the federal dollars go once they leave the state agency, and particularly with an interest in how much goes to nonprofits. And so in taking dollars or taking numbers from the state's fiscal year 2025, the team examined the top 3 agencies receiving federal dollars: the Department of Health and Human Services, Department of Education, and Department of Agriculture. Now, I want to note that the Gwynn Center set out to map all federal funding dollars that flow through the 5 state agencies that receive the most federal funding support. However, the team could only capture a partial picture because key data were inconsistent or unavailable. Additionally, funds that passed from the state through local governments or through school districts to nonprofits were not captured in this analysis, so the utilization of nonprofits by the state for direct service delivery and the amount of federal dollars that go to those nonprofits is actually greater than what you see in this snapshot. So the team was able to utilize state fiscal data to examine a snapshot of $818 million that passed through Nevada's top 3 state agencies that engaged in federal grant distribution in state fiscal year 2025. And overall, the team found that 57% went to local school districts and charter schools, 17.5% went to local governments, and 17.5% went directly from the states to nonprofits. Drilling down even deeper into the Department of Health and Human Services pass-through, the team found that 44% went to local governments and 40% went to nonprofits. I would also direct this body as well as the public to go to the appendix, where it outlines aggregate data analysis by department, budget account, and the pass-through entity receiving funds from the state agency budget accounts. Although this report simply provided a snapshot, there were several policy considerations that emerged for this committee and this body inevitably to consider. The first is to invest in data infrastructure. Without a comprehensive statewide system for tracking federal dollars from appropriation to final use, lawmakers lack the visibility needed to anticipate risks, respond to federal funding changes, or ensure resources reach communities and organizations that serve them. Second, to conduct an audit of service continuity risks. Nevada's dependence on federal pass-through dollars combined with its low per capita federal funding creates a fragile foundation for the state's service delivery system. And third, that future research is necessary, including a closer examination of the direct impacts of federal funding on nonprofits is needed, analyzed for small, medium, and large nonprofits, looking at the role that federal funding plays and the impact on services should these fundings be disrupted. More specifically, some of the questions to consider. What has been or is anticipated to be the effect of federal budget cuts on the provision of services through local nonprofits? Have or will such cuts imperil organizations in general or specific services? What would the cost be to the state to replace any of those lost federal dollars? And what would be the difference in cost to deliver those services through a government agency versus through the nonprofit entities? If you're interested in reading the full report, you can go to our website, gwincenter.org, and you'll find the federal funding briefs, both parts 1 and 2, as well as the legislatively approved budget analysis from this biennium, and the Medicaid brief. With that, I want to thank you, and I stand for any questions alongside with my partner, Mark Krimpatic, who is on Zoom.
Thank you. Thank you all for being here. Thank you for the presentation. Members, questions? Okay, well, I have plenty. So I think that you've heard, if you've been with us throughout the course of today, a number of immediate concerns relative to the effects of HR 1 on the state and specific populations. The nonprofit sector, in my experience, is often delivering services to that middle group that doesn't qualify for services elsewhere. I'm curious to know, has there been any modeling done with regard to anticipated changes in philanthropic support of the nonprofit sector, given the new provisions in HR 1?
Madam Chair, Jill Tolles for the record. That is part of our team's interest in further research. As you noted, and as you've heard from other presenters throughout the day, there's been a double impact. There's been the impact of 3 different changes at the federal level can impact nonprofits. So it could be the loss of government funding at the source. It could be pauses or delays to the distribution of funds, or to stop work orders that interrupt work. And those have a tremendous impact on our nonprofits. The other side to that is the changes in tax benefits for philanthropy that is reducing the amount of giving. So we would like to study that in a deeper capacity and would welcome that partnership.
Thank you. I appreciate that. Certainly that seems to be of great concern. Yes, you can. Go ahead.
Thank you, Jen Quintero with United Way for the record. I also want to share that what we've seen is that due to the changes in mission, based on just limitations to the DEI language or other restrictions, we have seen that our funders are changing their priorities, which in turn affects how they fund nonprofits in our work. So just another indirect way in which the changes are affecting or impacting the nonprofit sector.
Thank you for that clarification. Thanks for getting that on the record.
Madam Chair, if I could add on one more to the record, I do have a data point for you.
Go ahead.
Jill Tolles for the record. In our report, we did highlight that nearly half of an average nonprofit's income come from charitable giving, and the share of Nevada's small business budgeting donations dropped from 67.1% in 2024 to 56.6% in 2025, and it is anticipated that we will see further drops as a result of those changes.
Thank you for that clarification. I would additionally ask if we could chase the numbers about corporate philanthropic contributions, given that their tax policy is changing, versus personal or individual philanthropic contributions? And what are the tax implications relative to that? If our nonprofit sectors are primarily funded largely through philanthropic dollars, not just federal grants, I think that we have to look at what is personal giving and what are the effects of that on the service delivery as we continue to see the impacts of HR1 across the nonprofit sector. And so working to shore up a food bank, what other philanthropic support is the food bank then going to have to make up as a result of changes in charitable contributions to the organization, both corporate and personal? And so I'm most curious to learn about that and what are the long-term effects to the nonprofit sector where we're able to cover that as that safety net in between. Okay, members, any other questions? No, thank you. Thank you so much for providing the information and the detail. Mr. Kompatek, I want to say thank you for being here. Is there anything that you'd like to add to this conversation that we perhaps need to be aware of as we consider HR1?
Thank you, Madam Chair. Mark Kompatek for the record. I have nothing further to add. Thank you.
Thank you. We were successful in officially getting you on the record. I appreciate that. Okay, we will officially close this agenda item, and I will say thank you all for being here. Thank you for presenting on the nonprofit sector and the effects of HR1. That moves us to the next item on our agenda, which is public comment. We'll start with public comment for those who are here in our physical locations. If you'd like to offer public comment here in Las Vegas or in Carson City, please come forward and take the table. Please remember to clearly state and spell your name for the record. We'll limit your comments to 2 minutes. Also, you are welcome to call in. Thank you. If you would like to call in to provide testimony during public comment period, please dial 888-475-4499. And then when prompted, hit the meeting ID number at 857-3089-0851 and then press the pound sign. We'll go ahead and start here in Las Vegas. Welcome. Thank you. You may begin when you're ready.
Good afternoon. Thanks for having us. My name is Elisa Caffaretta. I'm the Executive Director of the Children's Advocacy Alliance. And we just want to raise the issue of nationally, we know that 1 in 5 children are at risk of losing their Medicaid coverage as a result of HR1. I know they're specifically exempted from the main cuts, but 2 specific risks to children that we know of. One is the immigrant family exclusion. So now children in mixed families, both of their parents have to be in categories that are still covered in order for them to maintain their Medicaid coverage. And as I know you're aware, Nevada has a very high rate of mixed families. So we're going to be seeing children lose their coverage in that way. And also it's been reported that HR1 has rules against raising the reimbursement rates for pediatricians in MCOs. I haven't seen this discussed, so I haven't been able to run down the exact impact here, but we know we have a severe shortage of pediatricians in Nevada, and raising reimbursement rates is one way to attract doctors and specialists. So if this is a decision point that the state can make, that would be great to investigate. But overall, we're standing ready to work with you to make sure as many children maintain their Medicaid coverage as possible. We really appreciate you having the hearing to investigate what the impacts of this law will be so we can start to find solutions. Thanks for your attention.
Thank you. Seeing no one else here in person in Las Vegas and no one at the testimony table in Carson City, we'll go to the telephone lines. AVH, is there anyone on the telephone line who would like to offer public comment at this time?
Chair, the public line is open and working. We have no callers at this time.
Thank you, AVH. Okay, members, that leads us to the next item on our agenda. Our next meeting will be held on Tuesday, May 12th, starting at 9 a.m. The chair is planning to be in Carson City for that meeting. You are welcome to attend in either location that you see fit. And for now, we are adjourned.